Di usia yang masih sangatlah muda, Unjaya terus bertransformasi, mewujudkan cita-cita menjadi universitas yang unggul dan berwawasan global. Sebagai universitas milik Yayasan Kartika Eka Paksi, di bawah binaan langsung TNI Angkatan Darat, Unjaya menjawab tantangan pendidikan tinggi di era disrupsi dengan bertransformasi melalui penguatan wawasan global dan ketahanan nasional dalam visi dan misinya, serta berpegang teguh pada nilai-nilai kejuangan Jenderal Ahmad Yani. Berbagai prestasi di bidang akademik, kreativitas, inovasi, dan kemahasiswaan banyak dicapai para Ahmad Yani muda. Selain itu, pengembangan keilmuan melalui metode student-centered learning dan project-based learning, magang, program kewirausahaan mahasiswa, festival karya mahasiswa, dan Ahmad Yani Mudapreneur merupakan salah satu bentuk transformasi ekosistem Unjaya agar mampu berdampak lebih luas bagi masyarakat. Sebagai lanjutan dari upaya penguatan internal dan transformasi digital, Unjaya menata kembali hubungan antar unit kerja untuk meningkatkan layanan yang efektif, efisien, dan transparan sebagai tanggung jawab perguruan tinggi sebagai salah satu lokomotif perubahan. Proses transformasi tersebut ditandai dengan aktivasi Pusat Akses Terintegrasi untuk Optimalisasi Tata Kelola atau Patriot. Patriot merupakan sistem informasi terintegrasi yang menyatukan semua layanan di Unjaya dalam satu genggaman. Transformasi tersebut menjadi salah satu bentuk komitmen Unjaya untuk membentuk masa depan pendidikan yang menjangkau lebih banyak, melayani lebih dalam, dan berdampak lebih luas bagi generasi penerus bangsa yang nasionalis, patriotik, heroik.
Yogyakarta adalah kota yang penuh dengan sejarah, budaya, dan semangat kebangsaan. Kota di mana setiap jalan berasa dijahit erat dengan kisah-kisah kepahlawanan dan pengabdian kepada negara. Dan di tengah-tengah gemerlapnya Yogyakarta, terdapat sebuah institusi pendidikan yang mengemban misi besar. Selamat datang di Fakultas Kesehatan Universitas Jenderal Ahmad Yani, sebuah tempat di mana semangat kebangsaan dipelihara dan para pemimpin masa depan kita dibentuk. Di sini, para pendidik bekerja tanpa lelah untuk memastikan bahwa pendidikan yang diberikan sesuai dengan standar pendidikan nasional. Mereka adalah pemimpin yang bijaksana yang membimbing mahasiswa dalam perjalanan mereka mencapai mimpi dan potensi tertinggi mereka. Fakultas Kesehatan Universitas Jenderal Ahmad Yani memiliki 8 program studi. Prodi Keperawatan S1 merupakan program pendidikan tahap akademik yang bertujuan untuk mempersiapkan mahasiswa menjadi calon perawat profesional melalui pendidikan berkelanjutan pada tahap profesi. Pada tahap akademik ini, mahasiswa dibekali dengan pengetahuan terkait teori dan dasar-dasar ilmu keperawatan melalui pembelajaran di kelas, laboratorium, dan juga praktik. Prodi Profesi Nurse merupakan program lanjutan dari pendidikan sarjana keperawatan untuk mempersiapkan lulusan menjadi perawat profesional. Pengalaman belajar dilaksanakan di rumah sakit, puskesmas, klinik maupun masyarakat selama 1 tahun. Prodi Kebidanan D3, program pendidikan vokasi yang mempersiapkan mahasiswa untuk menjadi bidan yang terampil dalam memberikan pelayanan kebidanan kepada remaja, ibu hamil, ibu melahirkan, ibu pasca melahirkan, bayi baru lahir, neonatus, bayi, balita, dan ibu klimakterium, serta terampil dalam memberikan pelayanan komplementer kepada ibu dan anak. Prodi Kebidanan S1 merupakan program studi yang mempersiapkan mahasiswa menjadi calon bidan profesional yang secara akademik dipersiapkan untuk menempuh jenjang pendidikan profesi, sehingga dapat memberikan pelayanan kebidanan sesuai kompetensi bidan. Prodi Profesi Bidan. Prodi Profesi Bidan merupakan program lanjutan dari pendidikan sarjana kebidanan untuk mempersiapkan lulusan menjadi bidan profesional. Pada tahap ini, mahasiswa dibekali dengan pembelajaran praktik di berbagai wahana praktik, meliputi rumah sakit, puskesmas, klinik pratama, dan praktik mandiri bidan yang ditempuh selama 1 tahun. Prodi Rekam Medis. Program studi ini membekali mahasiswa dengan pengetahuan dan keterampilan untuk mengelola informasi medis dan kesehatan berbasis elektronik, termasuk pengumpulan, penyimpanan, analisis, dan penggunaan data kesehatan yang penting untuk pengambilan keputusan klinis dan administratif. Prodi Teknologi Bank Darah. Program studi ini fokus pada pengembangan teknologi terkait pengelolaan penyediaan dan penggunaan darah untuk kepentingan transfusi dalam konteks pelayanan kesehatan, termasuk proses pengumpulan, pengamanan, penyimpanan, pengujian mutu dan distribusi darah, serta produk darah lainnya. Prodi Farmasi S1. Program studi farmasi ditempuh selama 4 tahun untuk mempersiapkan mahasiswa menuju jenjang profesi sebagai apoteker profesional. Pada program studi ini, mahasiswa akan mempelajari tentang obat-obatan, dosis, efek samping, interaksi obat, dan cara memberikan informasi serta layanan farmasi kepada pasien guna mewujudkan kesehatan yang optimal. Di sini, kami bangga menyediakan sarana dan prasarana bagi mahasiswa untuk meraih potensi terbaik mereka. Ruang kelas. Ruang kelas kami didesain dengan nyaman untuk menciptakan lingkungan belajar yang inspiratif, dilengkapi dengan teknologi terkini dan fasilitas yang memadai. Setiap kelas mencerminkan standar kualitas tinggi kami dalam pendidikan. Ruang tutorial. Tempat di mana diskusi dan interaksi antara dosen dan mahasiswa menjadi inti dari pembelajaran. Ruang tutorial kami dirancang untuk mendukung kolaborasi dan pemahaman mendalam tentang materi pelajaran. Lab terpadu. Laboratorium terpadu menyediakan fasilitas lengkap untuk pembelajaran praktikum mahasiswa semua program studi. Dengan peralatan modern dan ruang yang luas, mahasiswa dapat mengeksplorasi konsep-konsep ilmiah secara praktis. OSCE Center. Di sini, mahasiswa dapat mengasah keterampilan klinis mereka melalui simulasi yang realistis. OSCE Center dilengkapi dengan fasilitas terkini untuk mempersiapkan mahasiswa menjadi tenaga kesehatan profesional. Lab komputer. Fasilitas laboratorium komputer menyediakan akses ke perangkat keras dan perangkat lunak terbaru. Dengan ruang yang nyaman dan fasilitas yang lengkap, mahasiswa dapat mengembangkan keterampilan teknologi yang diperlukan di era digital ini. Lab CBT, Computer Based Test. Lab ini dirancang khusus untuk ujian berbasis komputer, menguji pemahaman mahasiswa dalam format yang interaktif dan adaptif. Ruang webinar. Kami juga menyediakan ruang webinar yang dilengkapi dengan teknologi mutakhir. Fasilitas ini juga bisa untuk menyelenggarakan seminar, workshop, dan presentasi online yang interaktif dan informatif. Asrama mahasiswa. Untuk kenyamanan dan kemudahan akses, kami menyediakan asrama mahasiswa yang modern dan aman. Ini adalah tempat yang nyaman bagi mahasiswa untuk tinggal dan berkembang dalam suasana akademis yang mendukung. Perpustakaan. Koleksi perpustakaan kami mencakup berbagai sumber belajar, mulai dari buku dan jurnal, baik cetak maupun elektronik. Ini adalah tempat yang ideal bagi mahasiswa untuk mengeksplorasi pengetahuan dan melakukan riset. Student Corner. Tempat bertemu, berdiskusi, dan berkolaborasi antar mahasiswa. Student Corner adalah pusat kegiatan sosial dan akademis di kampus kami. Lapangan basket. Untuk menjaga keseimbangan antara belajar dan kesehatan jasmani, kami memiliki lapangan basket. Ini adalah tempat yang sempurna bagi mahasiswa untuk melepaskan energi dan menjaga kebugaran fisik. Apotek. Kami juga menyediakan apotek di kampus, memastikan kebutuhan kesehatan mahasiswa dan masyarakat umum terpenuhi dengan baik. Fakultas Kesehatan Universitas Jenderal Ahmad Yani siap membentuk para Ahmad Yani muda yang nasionalis, patriotik, heroik. Bersama-sama kita akan melangkah maju menuju masa depan yang lebih baik untuk kemajuan Indonesia. Mari kita bersama-sama menjadi bagian dari perubahan di Universitas Jenderal Ahmad Yani.
Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta siap mendidik dan mempersiapkan para Ahmad Yani muda bidang kesehatan sebagai generasi penerus kejayaan bangsa Indonesia.
Unjaya, nasionalis, patriotik, heroik.
Yogyakarta, kota istimewa yang dikenal sebagai denyut nadi pendidikan Indonesia. Disinilah ribuan mimpi dan cita-cita masa depan dirajut di tengah atmosfer akademisi yang kental ini. Universitas Jenderal Ahmad Yani hadir sebagai kawah candra di muka, mendedikasikan diri untuk melahirkan generasi kesehatan yang unggul dan berjiwa kebangsaan.
Selamat datang di program studi farmasi S1 Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta, Unjaya. Prodi Farmasi Unjaya memulai operasional pembelajaran pada tahun 2017 dan telah memperoleh akreditasi B dari LAMPTKES pada tahun 2021. Prodi Farmasi Unjaya berkomitmen untuk terus meningkatkan mutu menuju akreditasi unggul. Visi Prodi Farmasi adalah menjadi program studi yang unggul, berwawasan global, memiliki penciri promosi kesehatan di bidang kefarmasian yang berbasis bukti, dengan semangat kejuangan Jenderal Ahmad Yani. Prodi Farmasi Unjaya memadukan pendidikan kefarmasian yang berwawasan global dengan promosi kesehatan berbasis bukti, agar lulusan tidak hanya menguasai obat dan produk kesehatan, tetapi juga mampu berperan aktif dalam edukasi, advokasi, dan pemberdayaan masyarakat.
Perkuliahan dirancang selama 8 semester dengan total 146 SKS, mengacu pada kurikulum KKNI, APTFI, serta standar profesi apoteker. Pembelajaran menerapkan pendekatan student-centered learning untuk menumbuhkan kemandirian dan berpikir kritis. Prodi Farmasi Unjaya didukung fasilitas pembelajaran lengkap, modern, dan terintegrasi sistem informasi. Mulai dari ruang kelas representatif, perpustakaan dengan koleksi pustaka yang memadai, ruang CBT, evaluasi dilakukan secara objektif melalui komputer based test CBT. Ruang OSCE, Objective Structure Clinical Examination OSCE, guna menjamin kompetensi yang terukur. Kegiatan akademik diampu oleh dosen berpengalaman dengan kualifikasi profesor, doktor, dan magister dari 5 kelompok keilmuan. Dosen kelompok keilmuan teknologi farmasi, dosen keilmuan teknologi biologi farmasi, dosen kelompok keilmuan kimia farmasi, dosen kelompok keilmuan farmasi klinik dan komunitas, dosen kelompok keilmuan manajemen farmasi. Serta didukung oleh staf kependidikan prodi yang terdiri dari laboran dan admin. Kami juga memiliki laboratorium terstandar yang terdiri dari Laboratorium Teknologi Farmasi, Laboratorium Kimia Farmasi, Laboratorium Biofarmakologi, Laboratorium Bahan Alam dan Mikrobiologi, Laboratorium Farmasi Klinik dan Komunitas, serta Laboratorium Instrumen dan Penelitian. Mahasiswa farmasi Unjaya aktif memperoleh pencapaian di berbagai ajang kompetensi bergengsi tingkat nasional, khususnya dalam bidang kefarmasian, sains, dan riset ilmiah. Kami mempersiapkan sarjana farmasi berwawasan global, adaptif, serta berkarakter profesional dan humanis. Selain keunggulan akademik, kami juga fokus pada peningkatan leadership dan soft skill mahasiswa melalui Himpunan Mahasiswa Farmasi atau Himafar. Berbagai kegiatan prestatif rutin dilaksanakan, mulai dari keikutsertaan dalam International Society Pharmaceutical Engineering (ISPE), pelatihan kepemimpinan manajemen mahasiswa farmasi (LKMMF), musyawarah besar, Pharmafest, hingga berbagai workshop pengembangan diri. Ekosistem organisasi yang kuat terbukti melahirkan budaya prestasi yang gemilang. Profil lulusan kami mencerminkan integrasi ilmu dan etika sebagai caregiver, communicator, decision maker, manager, leader, researcher, teacher, entrepreneur, long life learner, serta health promoter. Lulusan sarjana farmasi memiliki peluang karir luas dalam pelayanan kefarmasian di rumah sakit dan apotek, industri farmasi pada bidang produksi, QC dan R&D, regulasi pemerintahan di BPOM atau Kemenkes, wirausaha produk herbal dan startup digital, hingga menjadi akademisi dan peneliti. Upaya kami adalah terus meningkatkan kualitas dan menghasilkan lulusan berkarakter. Bergabunglah bersama kami, program studi farmasi, Fakultas Kesehatan Universitas Jenderal Ahmad Yani, Yogyakarta.
Farmasi Unjaya, nasionalis, patriotik, heroik.
Selamat datang di PT Kairos Jaya Sejahtera, sebuah perusahaan PMDN yang didirikan di Kabupaten Sleman, Daerah Istimewa Yogyakarta pada tahun 2014. Kami hadir untuk memberikan pelayanan distribusi khususnya dalam bidang laboratorium. Visi kami adalah untuk menjadi distributor berskala nasional yang menjadi pilihan utama bagi pelanggan dan mitra usaha. Dengan berlandaskan pada nilai profesionalisme dan humanisme, mendorong kami untuk melakukan kegiatan distribusi yang terstandar sehingga mampu memberikan layanan dan produk yang berkualitas. PT Kairos Jaya Sejahtera hadir untuk menjadi mitra dalam setiap kegiatan laboratorium Anda. Kami memiliki rentang produk yang luas untuk melayani kebutuhan laboratorium, seperti produk untuk penelitian genom dengan menggunakan PCR, penelitian protein dengan metode Western blot, immunohistochemistry, ELISA, dan bioassay lainnya. Penelitian mikrobiologi, sel kultur, kimia analisa, dan penelitian terkait life science lainnya. Pelayanan informasi yang detail terhadap produk dimulai dari tahap pre-order hingga after sale service menjadi kunci keberhasilan kegiatan laboratorium pelanggan kami. Standar operasional prosedur dalam kegiatan distribusi diterapkan sedemikian rupa sesuai dengan kebutuhan setiap produk. Proses penerimaan, penyimpanan, dan pengiriman barang diawasi dengan ketat sesuai dengan standar mutu yang ditetapkan. Didukung oleh sumber daya manusia yang terlatih dan sarana prasarana yang terkendali, menciptakan sinergi dalam menjaga mutu produk selama distribusi. Sistem informasi perusahaan yang diintegrasikan pada semua divisi meningkatkan kecepatan dan akurasi data dalam kegiatan distribusi, sehingga proses distribusi dapat berjalan dengan prima. Kami, PT Kairos Jaya Sejahtera, memberikan layanan purna jual untuk memastikan terciptanya kepuasan pelanggan. Kami melayani diskusi pada tahap pemilihan spesifikasi demi mendapatkan produk yang sesuai dengan kebutuhan pelanggan. Pendampingan kegiatan laboratorium dalam rangka menciptakan keberhasilan penggunaan produk adalah salah satu fokus kami dalam melayani pelanggan. Selain itu, dengan senang hati kami akan berkolaborasi dalam kegiatan pengembangan laboratorium. Berkat anugerah Tuhan yang Maha Kuasa, serta segala usaha dan komitmen dari seluruh tim PT Kairos Jaya Sejahtera, sampai saat ini PT Kairos Jaya Sejahtera dapat melayani distribusi ke sebagian besar wilayah di Indonesia. Dengan semangat, doa, dan upaya dalam menjamin mutu distribusi, PT Kairos Jaya Sejahtera akan melayani dengan lebih baik dengan harapan akan terciptanya kesuksesan dan kemajuan dunia usaha, ilmu pengetahuan, kesehatan, dan bangsa Indonesia.
Halo, mahasiswa farmasi Indonesia, sudah pakai aplikasi obat apps belum? Aplikasi belajar farmasi nomor 1 di Indonesia. Buat belajar farmasi lebih asik dan seru. Yuk cobain 5 fitur super keren yang ada di obat apps. Fitur pertama, jenjang pendidikan dan persiapan ujian. Di obat apps, semua jenjang pendidikan farmasi mulai dari SMK, D3, S1 Farmasi, dan profesi apoteker punya kurikulum terstandar dan materi tersendiri. Bahkan, memfasilitasi kamu untuk persiapan ujian UKAI, UKTTK, hingga masuk apoteker, dijamin deh lulus. Fitur kedua, Journey Belajar Farmasi Lengkap. Belajar farmasi lebih menarik dan lengkap karena ribuan video materi yang tersedia dilengkapi dengan ribuan evaluasi kuis dan latihan soal, hingga pembahasan soal. Juga tersedia ribuan soal ujian farmasi dari semua jenjang pendidikan yang telah dibedah oleh super mentor dengan lengkap, beserta tips dan trik pengerjaannya. Yakin deh, kamu bakalan paham, karena semua kontennya telah disupervisi oleh ahlinya. Fitur ketiga, Live Teaching. Belajar farmasi kapanpun dan dimanapun, dipandu oleh super mentor, dosen, hingga praktisi melalui live teaching. Gak hanya mengasah hard skill, tersedia puluhan tema soft skill seperti Pharmapreneur, Communication, hingga Career. Kamu semakin mantap bersaing di era global. Fitur keempat, Try Out dan kuis mingguan. Kerjakan ribuan kuis materi kefarmasian dan ratusan tryout ujian dari berbagai jenjang pendidikan farmasi. Menangkan hadiah jutaan rupiah setiap minggunya. Fitur kelima, buku digital. Zaman sekarang, semua serba digital. Yuk hemat dan efisien biaya dengan menggunakan buku digital. Tersedia ratusan buku digital farmasi yang bisa kamu jadikan referensi dan belajar. Lebih mudah, terjangkau, dan lengkap pastinya. Ayo download dan install sekarang juga aplikasi obat apps di gadget kamu dan jadi bagian dari revolusi pendidikan farmasi Indonesia. Obat apps tersedia di Play Store dan App Store.
Recording in progress.
Ladies and gentlemen, may I have your attention please? Our session is about to begin. Please turn on your camera and use the virtual background provided by the committee. To ensure the event runs smoothly, all participants will be mute. Microphones will be enabled during the discussion session. We would also like to remind all attendants to complete the attendance form, which has been provided by the committee through the link posted in the chat room. Good morning, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. Welcome to the second Unjaya International Conference on Pharmacy and Pharmaceutical Science with our grand theme, Strengthening the Role of Pharmacists in Global Health Issue. I am Widya Dwi Handayani, wearing traditional attire from North Sumatra, and I will be your master of ceremony for the next 2 days. First of all, I would like to extend my warm greetings to the chairperson of the Executive Board, Kartika Eka Paksi Foundation, Brigjen TNI Purnawirawan, Ahmad Dimyati SH. Director of Unjaya, Profesor Triana Hertiani. Unjaya Vice Rectors, Mrs. Lily Yulaika and Mrs. Weni Safitri. The Dean of Faculty of Health, Dr. Ida Nursanti. Vice Deans, Mrs. Ngatoyatur Rohmani and Mrs. Ekawati. Our keynote speaker, Mr. Roy Himawan from Ministry of Health of the Republic of Indonesia. Our distinguished speakers, Associate Professor Sharif Hanafi Mahmud from University of Alberta, Canada. Professor Bandana Saini from University of Sydney, Australia. Professor Yoshihiro Hayakawa from Institute of Natural Medicine, University of Toyama, Japan. And Dr. Kurnia Rahayu Purnomosari from Universitas Jenderal Ahmad Yani, Yogyakarta, Indonesia. And all respected participants who are joining us today. Thank you very much for being us today. Ladies and gentlemen, this international conference is held in collaboration with many universities and sponsors. We would like to express our sincere gratitude to our co-host, Universitas Jenderal Ahmad Yani Cimahi, Universitas Gadjah Mada Yogyakarta, Universitas Muhammadiyah Yogyakarta, Universitas Hang Tuah Surabaya, Universitas Mandala Waluya Kendari, Universitas Pekalongan, Universitas Jember, Sekolah Tinggi Ilmu Kesehatan Maluku Husada, Universitas Nadatul Ulama Yogyakarta, Universitas Sumatera Utara, Sekolah Tinggi Farmasi Indonesia Bandung, Sekolah Tinggi Farmasi Padang, Universitas Bengkulu, Universitas Wahid Hashim Semarang, Akademi Farmasi Yogyakarta, Universitas Mahasaraswati Denpasar, I3L University Jakarta. And we would also like to extend our sincere appreciation to our sponsors, CV General Labora, PT Abadi Nusa Usaha Semesta, PT Ditek Jaya, PT Kairos Jaya Sejahtera, PT Almega Sejahtera, CV Krishna Utama, Obat Apps. Thank you very much for your valuable support. To begin our conference with blessings, please join us in a moment of prayer according to your own faith. Let us pray for our family who have been affected by this disaster in Sumatra. Amen. We hope this brings blessings to our event. Our thoughts and prayers are with all families in Sumatra. On behalf of the committee, we extend our deepest condolences for the recent flooding and landslides that have impacted several regions in Sumatra. Ladies and gentlemen, let us begin with the opening ceremony. Please be prepared for the national anthem of Indonesia, Indonesia Raya, followed by Unjaya March.
Indonesia
Ladies and gentlemen, let us begin this event by respectfully inviting the chair of the committee, Mrs. Devika Nurhasana, to deliver her report.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, distinguished guests, esteemed speaker, respected colleagues, and all participants joining us today. My name is Devika Nurhasana, and it is a great honor for me as the chair of the organizing committee of the second Unjaya International Conference on Pharmacy and Pharmaceutical Science, hosted by Bachelor of Pharmacy Study Program of Universitas Jenderal Ahmad Yani, Yogyakarta. On behalf of the organizing committee, I would like to express our profound gratitude to Head of Executive Board of Kartika Eka Paksi Foundation, Brigjen TNI Purnawirawan Ahmad Dimyati Sarjana Hukum, Rektor of Universitas Jenderal Ahmad Yani Yogyakarta, Profesor Dr. Renat Apoteker Triana Hertiani, Vice Rector of Universitas Jenderal Ahmad Yani Yogyakarta, Mrs. Lili Yulaiha, Master Kebidanan, and Mrs. Weni Savitri, Nurse, Master of Nursing Science. Dean of the Faculty of Health, Dr. Ida Nursanti, Nurse, Master of Public Health. Vice Dean of the Faculty of Health, Mrs. Ngatoyatu Rahmani, Nurse, Master of Nursing Science, and Mrs. Ekawati, Master Kesehatan. Head of Bachelor of Pharmacy Study Program, Apoteker Sugiono, Master of Science. Head of Apothecary Professional Study Program, Apoteker Novran Putra Pratama, Master of Science, for their guidance, trust, and unwavering encouragement in making this conference possible. We are honored to welcome our distinguished keynote speaker, Apoteker Roy Himawan, Master Kesehatan Masyarakat, as Director of Primary Healthcare Governance from Ministry of Health Republic of Indonesia. We would like to express our sincere gratitude to our esteemed speaker for sharing their valuable knowledge throughout the conference. Professor Yoshihiro Hayakawa from University of Toyama, Japan. Associate Professor Sherif Hanafi Mahmud from University of Alberta, Canada. Professor Bandana Saini from University of Sydney, Australia. Dr. Apoteker Kurnia Rahayu Purnomosari, Master of Science from Universitas Jenderal Ahmad Yani, Yogyakarta. To the entire organizing committee, thank you for your dedication, hard work, and teamwork throughout these past months. Your effort have made today's event possible and successful. Before I begin, allow me to extend our deepest condolences to our families affected by the recent flooding in Sumatra. Our thoughts and prayers are with all families and communities impacted by this tragedy. May they be granted strength, safety, and a swift recovery. Amin. Ladies and gentlemen, I hereby present the official report for the second Unicopps. This year, our grand theme conference is Strengthening the Role of Pharmacists in Global Health Issues. This conference will highlight the increasingly important role of pharmacists in addressing global health challenges, ranging from infectious diseases and chronic illness management to health system resilience, patient safety, and international collaboration. We hope this conference will strengthen the scientific contribution and professional capacity of pharmacists across various disciplines and regions. We are delighted to report the second Unicopps this year has attracted enthusiastic participation from researchers and practitioners representing many institutions. The total number of scientific presenters is as follows: 106 oral presenters and 53 poster presenters. This enthusiasm reflects the rising engagement in pharmaceutical research, innovation, and interdisciplinary collaboration. We hope this conference will inspire further advances in global health and professional practice. We would also like to express our sincere gratitude to our 17 co-host institutions, whose collaboration has greatly strengthened the academic quality and impact of this conference. Our heartfelt gratitude also goes to our sponsors, whose generous support has made this conference possible. CV General Labora, PT Abadi Nusa Usaha Semesta, PT Ditek Jaya, PT Kairos Jaya Sejahtera, PT Almega Sejahtera, CV Krishna Utama, and Obat Apps. Ladies and gentlemen, thank you for your participation and commitment to our conference. We hope our conference will be meaningful, inspiring, and beneficial to all as we continue strengthening the role of pharmacists in global health issues. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Mrs. Devika. Now, we are honored to invite Director of Universitas Jenderal Ahmad Yani Yogyakarta, Professor Triana Hertiani, to deliver the opening speech. Please welcome Professor Triana Hertiani.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, distinguished speakers, colleagues, researchers, students, and friends from Indonesia and across the world. Before we begin, I would like to express our deepest condolences to the recent national disaster in Indonesia. Our heartfelt thoughts and prayers may also to all the families and communities affected by this tragedy. It is a pleasure and honor to welcome you to the second Unjaya International Conference on Pharmacy and Pharmaceutical Sciences 2025, which in this year carries the theme Strengthening the Role of Pharmacists in Global Health Issues. Ladies and gentlemen, global health today is moving with unprecedented speed, shaped by pandemics, digital transformation, demographic shift, environmental pressure, and the growing need for equitable and sustainable healthcare. In this changing landscape, pharmacy is being reshaped at its very core. Digital technology is redefining what pharmacists can do. AI-supported diagnostics, telepharmacy, smart dispensary systems, and real-time pharmacovigilance are transforming how patients access and experience care. Data-driven decisions are no longer optional, they are essential. At the same time, precision and personalized medicine are becoming global priorities. AI-assisted therapeutic design, genomic-based treatment selection, and real-time monitoring of drug responses are influencing not only research and clinical practice, but also how future pharmacists must be trained. This shift demands professionals who understand medicines and the digital systems behind them, the algorithms, the analytics, and also the digital risk. Furthermore, sustainability has become non-negotiable. Green pharmacy must now guide every stage of the pharmaceutical lifestyle. From research and development, responsible raw material sourcing, and energy-efficient manufacturing to optimize distribution, rational use, and environmental safe disposal. This commitment spans all pharmaceutical domains, clinical services, community and hospital pharmacy, biotechnology, herbal medicine, and also pharmaceutical education. Sustainable development is not merely a trend, it is our obligation to global health and future generations. In this convergence of technology, personalization, and sustainability, pharmacists hold a unique strategic role, not only as experts in medicine, but as architects of solutions for a healthier and more resilient world. Dear participants, we are honored to welcome our distinguished speakers. First is Mr. Apotheker Roy Himawan S.Pharm MKM as a keynote speaker from Republik Indonesia Ministry of Health, and also Associate Professor Sherif H. Mahmud from University of Alberta, Canada, Professor Bandana Saini from University of Sydney, Australia, Professor Yoshihiro Hayakawa from Toyama University, Japan, and Dr. Apotheker Kunia Rahayu Purnomosari from Universitas Jenderal Ahmad Yani, Yogyakarta. And also a warm greeting as well to Professor Dr. Apotheker Afifah B. Sujiatmo MS and Professor Elin from Universitas Jenderal Ahmad Yani, Cimahi. Thank you for also being here with us. And our deepest appreciation goes to all our 17 co-host universities. Thank you to Universitas Jenderal Ahmad Yani, Cimahi, Universitas Gadjah Mada Yogyakarta, Universitas Muhammadiyah Yogyakarta, Universitas Hang Tuah Surabaya, Universitas Mandala Waluya Kendari, Universitas Pekalongan, Universitas Jember, Sekolah Tinggi Ilmu Kesehatan Maluku Husada, Universitas Nahdlatul Ulama Yogyakarta, Universitas Sumatera Utara, Sekolah Tinggi Farmasi Indonesia Bandung, Sekolah Tinggi Farmasi Padang, Universitas Bengkulu, Universitas Wahid Hasim Semarang, Akademi Farmasi Yogyakarta, Universitas Mahasaraswati Denpasar, dan NI3L University Jakarta. And also, thank you for our sponsors and media partners, to CV General Labora, PT Abadi Nusa Usaha Semesta, PT Ditek Jaya, PT Kairos Jaya Sejahtera, PT Almega Sejahtera, CV Krishna Utama, Obat Apps, PT Prima Medicina Hana Caraka, and Himafar. And also for the organizing committee for their dedication to making this conference possible. Today's program also includes parallel oral and poster session, where both emerging and senior researchers share new insights and innovative ideas. This is where perspectives broaden and future collaborations begin. I invite all participants to engage fully, listen deeply, question boldly, and connect meaningfully. And finally, Pharmacy today stands at the intersection of science, humanity, and sustainability. The choices we make, the innovations we pursue, and the values we nurture will shape not only healthcare, but also the resilience of communities across the world. With Bismillahirrahmanirrahim, I'm honored to officially open the second Unjaya International Conference on Pharmacy and Pharmaceutical Sciences 2025. May this conference sharpen our vision, strengthen our partnerships, and deepen our shared commitment to advancing global health. Thank you, and I wish you an insightful conference. Wassalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, thank you, Professor Triana, for your inspiring speech. Ladies and gentlemen, before we move on to the next agenda, we will have a brief photo session. Please kindly turn on your cameras and stay within the frame as we take the screenshot. We will capture the photo in 3, 2, 1. Thank you very much. Ladies and gentlemen, now we have come to our main agenda, the webinar session. We will begin with our keynote speaker. Mr. Roy Himawan from Ministry of Health of the Republic Indonesia will deliver a presentation on strengthening the role of pharmacists in advancing national pharmaceutical resilience. Mr. Roy Himawan, are you there? Mr. Roy Himawan, can you hear my voice? Mr. Roy Himawan, are you there?
Yep. Hello, madam. Thank you very much. I'm
Yes,
sorry
I
for
can
the
hear your voice
technical
clearly.
issue. Thank you. So, can I start the presentation now?
Yes, Mr. Roy Himawan, time is yours.
Thank you. Thank you very much, Madam, for the opportunity. First of all, I would like to congratulate the committee, um, Unjaya, for holding for a successful holding of the second Unjaya International Conference on Pharmacy and Pharmaceutical Science that held today on Wednesday, December 3, 2025. I would like also to greet distinguished speakers and distinguished participants of the event. I'm looking forward for the fruitful discussion and meaningful engagement as the head of committee mentioned to us previously. So I would like to present several updates and several information with regard to the role of pharmacists in primary healthcare and how did the government proceed to strengthen its role on this important aspect of our healthcare. So allow me to share the slide. So I do hope
Mr. Rohimawan,
all the participants.
is there
Yeah,
any kind of problem?
can 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 you see my slide now?
Yes.
Okay, so let me start the presentation.
Yes, Mr. You can start.
Okay, thank you very much, madam, for the allowance. So
My pleasure.
this morning I would like to present the several information with regard to strengthening the role of pharmacists in primary healthcare. But before that, I would like to start with the background that what happened in our health development nowadays. That we move forward to our transformation system, to our health transformation system, especially on primary healthcare, and how do we manage this as a standard of our health services? What is the expectation for pharmacists to be involved in this area? And the last one will conclude and some several information of the expectation from the pharmacist role. So first of all, I would like to start by informing the audience that the government in this new government tenure had decided to move and to proceed with a vision that all the all the people, all of the community will have the same opportunity to achieve a healthy life for along their life course. So this is what stated in our national term of planning of development plan that we say the vision is a health for all, and then this vision being disaggregated into 5 years tenure of development plan that we call it medium term of national development plan agenda. With the vision of this 5 year agenda is to achieve health for all with the indicators of life expectancy and total fertility rate. How do we manage and how do we achieve this situation is by providing 5 pillars started from improvement of public health and nutrition. And then the second one is free meal provision to fulfill nutrition needs. And then disease control and healthy life promotion and goes to strengthening health resilience capacity and empowered with a strengthened health services and governance. This is the agenda of the government. And when it comes to the health sector, because we also understand in government, we have several ministries. And when we talk about health agenda, then we come to the what we call it health master plan or RIPK, as you see on the left slide, that wishes to accomplish the mission with more concrete action started by a vision that a healthy and productive society for Golden Indonesia 2045, which indicated by several numbers of life expectancy, and then healthy adjusted life expectancy, or we may also know it as a HALE, and UHC coverage index, and added with total fertility rate. So this is something that we are trying to accomplish on the next 5 years to improve our society to be a healthy and productive one. And to achieve this, as we had on the government level, the ministry also stated that we will achieve 6 strategic goals to describe a healthy and productive society. Started from a healthy people, a healthy lifestyle community, goes to quality, equitable, and affordable health services, equipped with strong health system, effective governance and finances of health, and advanced health technology. This is something that will empower us in the next 5 years. As now we started on the first year, which is to move forward, to push the agenda forward of promotive and preventive actions. So this goes to our experience on the last 2 years, saying that we still have challenges. We still had difficulties on achieving. You may see on the indicate on the screen. I do apologize if there is any disruption on uh, 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 the internet signal. Health services that covers all of our people based on their age. You may see on the slide for those who are pregnant, uh, we still have challenges, and those with severe mental disorders, we also had challenges, and for the others, we are still struggling to provide a comprehensive healthcare for our people. So then this will lead us to the next information that based on our disease burden map provided by IHME, we may understand that in order to elevate our health status, our people health status, we are now able to identify what is the biggest health burdens based on their age group. As you may see on the age of babies and toddlers, children, teenagers, productive one, and elderly, now we're able to identify what is the highest burden of group. And by understanding that more or most of this burden are preventable, detectable. So now we are moving forward the agenda to prevent and to detect earlier of this health burden. So then by having that managed, we are trying to improve the quality of our people. So this will lead us to the information that now we are having a changing on pattern of disease in the last 10 years. As you may see on the slide, we are now facing a huge increase of non-communicable diseases, chronic diseases that should be prevented, that can be prevented to eliminate and to diminish the health and financial burden. As you may see also on the right side, the highest burden for our health financing came from cardiovascular diseases, cancer, stroke, and kidney failure that should be able to be detected and treated in the first and the very early stage of the to eliminate and to detect earlier and to treat earlier. So then we understand from our people habit based on our research on 2023, we do see that it is not an habit for our people, to our society, to have a routine health checkup. From the data mentioned that only 40% of our people who are having a non-communicable disease screening, even if we come more detail on the type of screening that they are performed, uh, you may see on the slide that we still have a big number of people who do not measure their blood sugar, do not measure their cholesterol level, even still have 40% of people who do not measure their weight and blood pressure. This is something indicate us that we should provide better opportunity for our people to do health in the frame of prevention and early stage intervention. So just an additional information for the background that not only on the term of preventing and promotive action, we do have also the burden of antimicrobial resistance. As you may see on the slide, we are now uh, having the burden of this resistance, including on the primary health care that should be able to be treated accordingly with good activity with a standardized intervention, including from the pharmacist as health manpower in this setting. So I would like to kindly ask the audience to join us on our agenda on this primary healthcare transformation. So based on the information provided previously, we would like to invite all the audience to deeply discuss and deeply understand what is the transformation of our health system. Based on our RIBK, RPGMN, now we are conducting a health system transformation covers not only those who are work on the supporting level like financing, workforce, and technology, but the biggest part of it is a primary healthcare level that started from education, primary prevention, secondary prevention, and improving the capacity of our primary healthcare. This is also supported by the transformation of our health system resilience that aim to provide resilience and of pharma and medical device sectors that will support all the health capacity in that picture. We are informing the colleagues that on the primary health services, you may see the examples and the concrete activity that provided, as you may see on the slide, start from enlargement or improving the immunization of our routine immunization by introducing new vaccines to provide better protection to our people from cervical cancer, pneumonia, and diarrhea, and then provide them with priority disease screenings that provided for all kind of ages. So then we were able to detect earlier the diseases and to treat them earlier, and improving our maternal and child health status by providing monitoring of growth and development routinely, including the pregnancy checkup that improved from 4 times to 6 times, including the use of ultrasound examination, and also provide ultrasound examination for breast cancer screening and conducting a congenital heart disease screening in our primary health care. This is something that now improve in our primary health services that aim to identify, to detect, and to treat earlier of the diseases that will provide us opportunity to provide better health quality for our people. So, as you may see on the slide that now presented, this is refer to our mission on the primary health patients that we focus on three things that later on I would like also to invite the pharmacists to join us on these three focus. The first one is we shift the focus from program based into life cycle based primary care. It means that if previously we are discussing based on diseases, we are discussing based on program, but now we are discussing based on the people who receive the services, that we see the life cycle as the main consideration of providing the care. The second focus is to bring the health services closer to the people by building the network up into village and hamlet level. This is also to include our opportunity to strengthen the promotive, preventive actions and to build our pandemic resilience. And the last one is to equip this activity to equip the primary activity with a local area monitoring system, digitalization, up until the village level health situation dashboard. So by having these three focus, we would like to involve all the primary care service providers, including pharmacists on their pharmacy on their pharmacist, and then also join us on the effort to cover, to reach all the population in a regular manner across Indonesia. This is something that makes the primary healthcare become more substantial to our discussion, that we are trying to contact, we are trying to reach all the population regardless of their geographical status and also their socio-economical status. So this is to inform you that what happened previously or what happened on the existing condition, that we see the health services is fragmented. As you see on the left side of the slide, you may see that our health services were fragmented. On the village level, you may see many boxes there. Also on the hamlets level, you also see many boxes on that level. Now, under the primary health information, we are providing a standardized model. We are standardized all the activity on the box by providing only single box intervention. This is what we call from program based into life cycle based. So now all the activity conducted on single box, providing a comprehensive care, try to reach the people up until the hamlet level, including through the home visit to our people. So by having this being standardized, we also make the standardized platform for the services. As you may see on the slide, starting from the right side of the slide, it is the lowest level of the services that provided in integrated health posts that exist on hamlet level. As you may see, these services designed across the life cycle, provided for a pregnant woman, postpartum ladies, also including for infants and preschoolers. You may see the type of services that are able to be provided on that level. And if the services is not sufficient, the people may come into what we call it auxiliary health center in the village level. That you may see more services available there, started from integrated ANC, goes to provision of additional nutritional intake in chronic energy deficient pregnant women, including that screening of violence against women and children. So this is something that available to be accessed by the people by reaching our auxiliary health center in the village level. And if the community, if the people wishes to have more services of the primary care, they may go into community health center provided in the sub-district level that will provide them with more comprehensive services that you may see on the middle row of the slide. We'll start from for no for having facility for normal delivery of pregnant women, including the dental and oral health services that provided in this facility. These services are designed based on the life cycle of the people. So you may see a different health services for every health or every age of our people. So this is to inform you again, the next slide, that the same arrangement provided for those who are on school age and adolescents, for those who are adults and elderly, trying to understand what is their health problem and to provide them with a comprehensive health services. This is also to include the services of pharmacy. We have the service of pharmacy that provided in sub-district in the facility that we call community health center that now provided for our people. But however, we do see also, and we do provide also in village and also in hamlet level, health check-up conducted through a rapid diagnostic test, or what we call it POCT, that may be able to access by people who are achieving or goes to a village level or even on a hamlet level. So this is something to inform you that we are standardizing our health services across our health aids and also in our across our health services. So this is to inform you then how the services work, how the primary care work for our people. I do apologize for not to need a slide of this or not to good presentation of the slide, but this to inform you by numerical step that whenever the facility of community health center found or detect health cases, in this slide you may see low ANC, pregnant woman with CED, chronic energy deficiency, or low immunization coverage or of region of area, then the community health center will provide the information to our village health center. Where at this facility there is health manpower, there is a nurse and midwife that were able to follow up into a hamlet level through integrated health posts. In this facility, in this site, we do have cadres that do the problem-based evaluation and do the follow-up to our people, our community. And whenever the cadre had finished the task, they will provide the report into village level, including by putting the information on our website, on our dashboard. So then the village level and the community health center level are able to understand what happened on the village or hamlet level as a follow-up of the problem found at community health center. This cycle is conducted routinely and conducted in a manner that Puskesmas or community health center village level will have the same goal of achieving the healthy lifestyle. So then I'll to the next information on standardizing our health services that provide on our regulation. So now, based on the newest ministry decree of implementation community health center, as stated on Ministry of Health Regulation number 19 on the year of 2024, we acknowledge the importance of pharmacists. We acknowledge their important role on providing primary care. That's why the pharmacists now are included on the minimum of or the minimal health workers that should be available on community health centers. We do understand the competency. We do understand the service that may be provided, and then by understanding that, we invite the pharmacists to work with other healthcare professionals providing a quality primary healthcare. So how do we provide a primary healthcare that we call it as a quality one? So we define the quality based on the algorithm, based on the care pathway that provided for each cases. So I do apologize if the slide contains of multi-language. On the box you may see the slide contains with Indonesian language, but we are happy to translate it later. That this slide informing us on the step of providing care that be should be followed by every healthcare worker in primary healthcare in community health center whenever they found a cases. So this is the guidance for all primary healthcare workers, including pharmacists, and to understand what is the activity, what is the aim, and how can they provide support of this activity. As you may see on the slide, this is a care pathway for tuberculosis case. The disease that is still a big burden on Indonesia setting, that whenever we found the disease of people that showing us or indicate us the sign of tuberculosis, we provide them several layer of screenings, started from family level, goes to village level, and goes to community health center level, where at the right side of the slide, you may see several activity provided or several actions to be followed up, including to provide um, uh, therapeutical intervention for their family. So if we found a person that positively diagnosed as a tuberculosis patient, it is a role of our healthcare services to provide not only for the patient, but also for the family or the closest contact with the patient with therapeutic intervention to provide them to make them away from the risk of contracted with tuberculosis. There's also there's also activity to refer them to a more proper health facility whenever the more comprehensive services needed to the patients. So this is already established on our health website. So then all the healthcare workers, including pharmacists, may refer to the document that we call it a care pathway. So we do understand that the pharmacist has a significant role on the health services. This is what we identify on our primary healthcare services based on the late previously care pathway slide, that we are observing that the pharmacy will have the capability, will have the role on management of our medicines, of our consumables, as you may see on the slide called SBMHP. It refers to consumables that we understand the pharmacist will have the capacity to do planning, to do procurement, to do accepting the product, to storage, and including to distribute, to the structure or withdrawal, and including to record and reporting, also monitor and evaluation of the management of these medicines and also the consumables. Not only on the management level, we do see the pharmacists had the capability to do clinical actions, like we call it assessment of service and service of drug recipe, providing pharmaceutical care, including to do monitoring drug therapy, the evaluation use of medicines, and monitoring of drug use. And not also to forget don't forget also their important role on education of drug use that should be accomplished in every healthcare services, including on primary healthcare. So that will describe all the role of the pharmacist on the primary healthcare. And now we inform the colleague on what do we have on the field in community health center of a pharmacy. So as you may see on the slide, informing you the provinces across Indonesia. We have 38 provinces across Indonesia, and the number of community health center across Indonesia in each provinces that goes up to a number of 10,000 and 300 community health center across Indonesia. And you may see the numbers of pharmacy that work on this public health center level as informed by our DG of Human Resource. It is informed that the number of pharmacists work on this public health center reached a number of 25,000 on this primary healthcare, making the ratio becomes goes to one pharmacist, or I guess one public health center will have two pharmacists on the locus. But this is a general number, and if you go deeper on district level, on sub-district level, you may see maybe there is a community health center equipped with more than two pharmacists, and there may be there also some community health center with no. The information to colleague that we also identified the number of pharmacy across Indonesia based on the data of our DG of Pharmaceuticals on May that inform us the number of pharmacy across Indonesia will reach about 41,000 facility in 38 provinces, whereas the number of pharmacists that work on this area goes up to 66,000 people work in this area, informing us the ratio or number of pharmacists per pharmacy will reach about I guess will reach about 1.2 people per facility. There also information from our Association of Indonesian Pharmacists that the number of pharmacists per our thousand population will goes up into 0.8 up to 1 per thousand population. This is to inform you the huge number of pharmacists that we have in the country that able to strengthen our primary health care. And now, what do we wish to our pharmacists? That we are informing them that they work in a network situation. they work on a network-based healthcare services on primary level. So if you see on the Indonesian context of primary healthcare, as you may also understand from previous slide, that we want to contact, we want to uh, we want to uh, we want to achieve and to contact all the people. We should work on a network arrangement. So then you may see on the slide, our primary healthcare services provided network-based health services. As you may see from the left side, network based on administrative setting that goes see on the next box, network based on additional units. It means that our primary healthcare services provided through our schools. And you may see the primary healthcare provided based on place work, so that when we work with our sector, our manpower, so then we work on with them, with offices, we work with industries, we work in informal setting like fisheries, fishermen, and to cope with all of the population there. We also work on referral system that equip our primary healthcare services with vertical referral, horizontal referral, and also back referral of the people. And we do also work in cross-sector area where our health actor in community health center also work with village government, also work with health partners, so they're able to provide services for all the people on their region. So this is something that we inform to our pharmacists that now we are able to understand the pharmacists also include on the services as a network region-based administrative and to gather with us to achieve our program and target, which is to provide the service for all the people. So then, by having that, we would like to deep dive to what do we have on the our national health insurance system on for pharmacists that we may call it like a referral back program that provide the opportunity for pharmacists to provide better services through the management of this referral back program. Started from the management of medication, including for providing services for a patient that referred back to our primary healthcare level from previous, which is hospital level. This is something that we also include on the decree that a patient that goes to referral back program should have the services of drug program reconcile, which is to provide opportunity for the pharmacist to do the services, to inform the patient what the drug should be taken when they goes back to primary healthcare, and to provide arrangement on the primary healthcare, a better arrangement for the patient that follow that the participant of referral back program. So by that, we would like to make a general conclusion for the role of pharmacists on primary health. We at least span for this four area, started from drug management, goes to interprofessional collaboration, and provide patient education that we wish also for pharmacists to involve on our prevention of disease that we call it like vaccination, that we call it counseling of healthy lifestyle, and also to provide uh, free health checkup that now we goes on national program for all the people. So by that, I would like to conclude the presentation by informing the colleague, the audience, that it is our agenda to strengthen the role of pharmaceutical service in our primary healthcare, started from providing systematic services for our people, and goes to distribution of our pharmacists across Indonesia, and to equip them and to include them on our integration of our primary healthcare services, and to ensure them to provide standardized services including the role of pharmacy and the care pathway implementation. And do not forget, we also would like to improve their competency, the capability, so they're able to provide services for all the people. So by having this, we would like to inform the colleague, it is our challenges, it is our aspiration that would like to implement the utilization of services that also speak by our previous head of committee that I that is also to for them to strengthen the network activity on primary health services, so then they will be able to do education and monitoring supervision of the drug use. By having this, we are sure that strengthening governance of our healthcare in primary health services will be to attain by substantive part of pharmacist activity to the role. So this is the end of my slide. Thank you for the opportunity, and I will provide it back to the moderator. Thank you very much.
Thank you, Mr. Roy Himawan, for your valuable insights. Ladies and gentlemen, we now proceed to the next session. This session will be led by our moderator, Mrs. Arina Titami. Mrs. Arina Titami is a lecturer at the Pharmacy Department of Universitas Jenderal Ahmad Yani Yogyakarta. She teaches, writes, and conducts research in the field of clinical pharmacy. Mrs. Arina Titami, the floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, esteemed college and participant. Thank you for joining us again in the morning session of our conference today. My name is Arina Titami, and I'm pleased to be moderating for our two speakers in this session, which centers on strengthening the role of pharmacists in global health issues. This morning, we will explore how pharmacy can expand their competency, enhance their contribution, and optimize their impact in responding to global health challenges. We are very privileged to be joined by two distinguished researchers from Canada and Australia who will present their insight and strategy perspective. Without further ado, let's begin our session. Please join me in welcoming our first speaker, Mr. Sharif Mahmud. Okay. Okay. Hello, Mr. Sharif Mahmud.
I can't. I muted. Sorry, I wanted to unmute myself, but I couldn't. Hello, everyone. It's my pleasure to be here with you. I will share my screen. Can you hear me well?
Pardon me, Mr.
Can you hear me well?
Yes, I can
you
hear
hear
your
me?
voice. Yeah.
Okay, perfect.
Okay.
Can you see my screen now?
Okay. First, before we proceed your presentation, please allow me to read your curriculum vitae to our participants, sir.
Okay, sounds good.
Okay.
Thank you.
Ladies and gentlemen, allow me to introduce Associate Professor Sharif Hanafi Mahmud, BSc Pharm, MSc, PhD, FN. She is a faculty member in the College of Health Science, Faculty of Pharmacy and Pharmaceutical Science at the University of Alberta. He received his Doctor of Philosophy degree from Harvard Medical School, Boston, Massachusetts, USA, 2019. Some of his latest publications are shown on the screen. His research primarily focused on pharmacotherapy and the clinical pharmacy field. On this occasion, Mr. Sharif Hanafi will share his valuable insight on the evolving role of pharmacists in personalized pharmacotherapy in Canada. Mr. Sharif Mahmud will highlight how pharmacy can enhance patient care by advancing their role in personalized pharmacotherapy within the Canadian healthcare system. To our participant, if you have any question during the presentation, please either raise your hand or submit your question via the Zoom chat or the YouTube comment section. All questions will be addressed during the question and answer session at the end of both presentations. Okay, Mr. Sharif Mahmood, may we begin?
Okay, sounds good.
Okay.
Hello, everyone.
Sir,
hello,
you
everyone.
will have 30 minutes for your presentation. Okay, Mr.
Okay.
Sharif Mahmood, the floor is yours.
Thank you. Thank you. Assalamu alaikum. Hello, everyone. My name is Sharif Mahmoud. It's my pleasure to be with you here today. I'm going to talk about the role of pharmacists in Canada, and they focus on some personalized pharmacotherapy as well. So I am originally from Egypt, and then I moved to Canada many years ago. Currently, my research lab, I focus on personalized pharmacotherapy in neurology. So the outline for today, I will talk about pharmacists in Canada and their evolving role in patient care, about patient assessment, and that is essential skill for pharmacists that they use in their day-to-day practice. And I will talk about the pharmacotherapy variability and precision medicine. So pharmacists in Canada. Pharmacists in Canada, they have multiple roles in multiple areas. So they are currently integral members of the healthcare team. They work not only in community pharmacies, they work in hospitals, primary care clinics, and also in specialized programs like neurology, transplant, and so on. They collaborate closely with physicians, nurses, and other healthcare professionals. Their role is they are part of the clinical decision makers. They optimize medication therapy using evidence-based guidelines. They identify the drug-related problems for patients with chronic illnesses and new other diseases as well. In addition, specifically in the hospital, they adjust doses based on the clinical status. They can order lab values, and also they do therapeutic drug monitoring. They are personalized pharmacotherapy experts. As you know, pharmacists are the drug experts. They apply pharmacokinetics, pharmacodynamics, the action and disposition of drugs, and also the pharmacogenomics. They tailor therapy for complex patients, in patients in neurology, in the ICU. I'm currently a practicing pharmacist as well in the neurosciences ICU. And also there's oncology, infectious disease as examples. In Canada, they have expanded scope of practice. In some provinces, like in Alberta, where I am from here, Alberta, we prescribe medications independently. We'll also, in some provinces, prescribe medications in collaboration with the physicians. They can order lab tests, interpret lab results, and manage ongoing therapy, and also administer vaccines and provide public health services as like vaccinations and others. As you can see here in this figure, this is the pharmacist scope of practice in Canada by province. If you can see at the top here, the BC, AB, these are the provinces in Canada and territories. And when there is a check mark, this means that they can do that. In Alberta here, they can independently also prescribe medications in addition to others like minor ailment conditions, smoking cessation, in an emergency, make therapeutic substitutions. They inject drugs, vaccines, influenza vaccine, and also the COVID vaccine. They can order lab tests, interpret the lab tests, and do more. Based on that, they conduct medication reviews and chronic disease management. As you know, patients with multiple disease conditions, like, for example, diabetes, hypertension, and asthma at the same time. This all could be complex patients with multiple medications, and they need the medication experts to help them to manage their medication. They support medication adherence and lifestyle counseling and lead transition of care initiatives. When I say leads transition of care initiatives, let's say someone got admitted to the hospital and now they are going to be discharged to home. Before discharge, they usually meet with a pharmacist. They go over the medication list, the medication that stopped, medication that started, and also the medication that modified in terms of dosing and so on. That and communicate with the healthcare provider or the other patient pharmacy in order to make sure that there is a seamless care. Research in literature is full of some research about pharmacists' role. They improve therapeutic outcomes and reduce medication errors and hospital readmissions. In addition, they enhance the access to care in undeserved area. As you know, pharmacists are the most accessible healthcare practitioners. If you want to speak to a pharmacist, you can go to the pharmacy and speak to one. And because of that, research showed that actually pharmacists involvement in care of patients with chronic illnesses leads to actually improving their outcome. These are some examples of those articles that show the pharmacist intervention in multiple disease management. Actually, they have an important role to play and improve their outcome and disease control. This was a glimpse of what pharmacists do in Canada. In order to do their duties, pharmacists need to master a skill. It's called the patient assessment, because patient assessment is an essential skill for all pharmacists, regardless of their practice setting. What's patient assessment? Patient assessment is a process of methodically collecting patient information while also using clinical judgment and therapeutic knowledge to identify patient actual and potential drug-related problems. So in order to do patient assessment, they need patient information, that's number one. Number two, they need to have a therapeutic knowledge, like knowledge of how those diseases are managed and treated, and clinical judgment, because every patient is different. And they need to have the clinical and critical thinking skills to make decisions on those patients in order to identify any actual and potential drug-related problems. Patient assessment is an essential component of a big framework that we teach our students in pharmacy schools about. It's called the patient care process. So what's the patient care process? It's a multi-step process. It starts with patient assessment. So the first step is to establish a relationship with the patient. For example, if a patient in a community pharmacy, they say, hi, my name is Sharif. I am your pharmacist here. How can I help you? And they start to say checking why the patient is seeking care. Is the patient, for example, is suffering from headache, for example? So why the patient is sick? Or maybe they're having constipation, or maybe just they're here to refill their medications. And based on that, the pharmacists start gathering relevant information, like the medical history and medication history, like their past medical history, social history, current medications, and any, when necessary, medication they're taking, any herbals, if they are smokers or not, and so on. Based on that data, they try to assess the patient, which is the patient assessment. And once they assess, they're saying, okay, they can identify a DRP, which we call a drug-related problem. For example, let's say the patient is having hypertension or high blood pressure. And they found out, the pharmacists find out that the blood pressure is not controlled, this is considered a DRP. So they can say this patient has hypertension that's uncontrolled and might need therapy modification. So there's a DRP now. So the next step would be is to do the care plan and develop the care plan and implement that care plan. So let's just going back to the patient with high blood pressure. We need to identify the alternatives. Does the patient need an AC inhibitor, or for example, ramipril, or an ARB, or an amlodipine, a calcium channel blocker, or something like that? So identifying the alternatives. And then decide on the advantages and disadvantages or pros and cons of each treatment. And based on that, deselect the treatment that's appropriate for the patient, given the characteristic of that patient. Because as you know, older adults might need different treatment from younger adults, as an example. And then implementing the plan. It's important to say that don't fire or forget. Like if they are implementing a plan, the plan should have a monitoring and follow-up. Who will be monitoring and when this will be monitored, right? So let's say if they started the medication for high blood pressure, who will be monitoring the blood pressure? Probably the patient. What if they experience side effect? Whom do they reach to? To their family doctor, for example, to their pharmacist, and so on. And they need to document that plan. And that patient care process is a cycle. It repeats itself. When the patient comes again, they repeat the whole sequence. But why patient assessment matters? Patient assessment matters because pharmacists are increasingly leading direct patient care initiatives. As you heard in the previous presentation and this presentation, that pharmacist role is expanding, right? And you need to have that patient assessment skill with them. And they are the most accessible healthcare professionals. Accurate assessment gives a safe, evidence-based pharmacotherapy decision. Like the proper diagnosis, proper assessment leads to proper treatment. The opposite is like if the patients, like if one of the main mistakes that maybe pharmacists can fall into is to jump into conclusions before doing proper assessment, which could be unsafe. And also, mastering this patient assessment skill is actually, it improves the interprofessional collaboration and continuity of care. Because pharmacists will, when they make a plan for a patient, they need to communicate to the healthcare provider, the physician, the family doctor, the plan, that what was done. And without proper assessment, this might not have good collaboration. So what are the steps of patient assessment in pharmacy? So someone presents to your pharmacy, they might be presenting for a symptom, like say having headache, or for a chronic illness, if it's an initial diagnosis, or a follow-up assessment. Let's say they want to refill their prescription. Pharmacists can do assessment at all these scenarios. Also, they can do complete medication review. Like it's like if the patient's like they're having time, saying like, okay, they are on 7 different medications. You want to sit down with the pharmacist and they do a complete patient review. Assessment should be done there. There are also other assessments like assessing any side effects, adverse reactions, and drug-drug interactions. There are some acronyms that we use to remember what to do, what to ask for in each situation. For example, in symptom assessment, we use something called Scholar. I will show that in the next slide. Chronic disease assessment, if it's initial assessment, we do the IESA or IESA, and the follow-up assessment, we do the 2 CAs. What are these scholars? So let's go. The first one is a Scholar. So remember, Scholar is used for symptom assessment. So asking about the S for symptoms, what symptom the patient is experiencing? What are the characteristics of these symptoms? What is the history? What the patient was doing when they experienced this symptom? The onset. When did it start? Location. If it's if you have abdominal pain, where is it located? Aggravating factors. What worsened the symptoms? And remitting factors. What the patient did to relieve these symptoms. So by following this acronym, pharmacists will remember what to ask for. We usually mix between open-ended and closed-ended questions. Closed-ended question is like questions like a yes, no kind of thing. And open-ended questions are asking the patient to describe their symptoms. Based on that, you will be able to assess those patients, identify red flags that warrant referral to the doctor, or maybe identify a minor ailment that can be treated. In terms of initial diagnosis, we do the IESA, which stands for indication, efficacy, safety, and adherence. So asking if they actually, when you assess a medication, let's say someone come to you with a prescription of a medication. Your first question is this medication indicated? Is it prescribed at an effective dose? Is it the most appropriate medication dose or not? Is the dose safe given the patient characteristics? Let's say the patient is having renal failure. Does the medication need renal dose adjustment, for example? And then assessing if the patient will be able to adhere, like be compliant to the medication. Adherence is an important piece, right? If the patient is not taking the medication, this is a big issue. So making sure that the patient has all the factors needed that will be able to comply with the medication. Can they afford the medication? Are they able to pay for it? Do they have a medication insurance to cover that? And also for many other things like adherence, like the frequency of administration. Like a medication that's once a day is patients more likely to adhere to once a day medication than multiple times a day. The two CAs is about follow-up assessment. Someone comes with a refill of their medication. They ask about adherence. Are they actually adhering to the medication? Is the disease under control, which is the C, control? Is the disease under control? Is blood pressure under control? Is diabetes under control? Is the patient experiencing any adverse effects from the medications? And then the complications, if there are any complications of the disease. We do the two CAs. When they ask this using this acronym, the patient pharmacist will be able to remember what's actually needed. But what about complete medication review? It's a mix of those. So once the patient needs the medication, complete medication review, the first step is to do a complete patient history, followed by writing the patient problem lists. When I say problem list, not the patient drug-related problems. Problem list, the diseases they're having, or any abnormal lab finding or any symptom. Then, if there are chronic illnesses or there are symptoms or if there are abnormal lab or physical assessment findings, they perform the 2CA for each illness, SCOLAR for the symptoms, and if any abnormal finding warrant referral or further investigation. When they do that complete medication review, will be able to properly assess those patients. So in terms of patient assessment, this is a resource for patient assessment. My textbooks about patient assessment in clinical pharmacy. And I'm excited to share that actually the 2026 edition will be released this January 2026, inshallah. And it has updates on all these steps if you're interested for more details in patient assessment. So the next step I wanted to mention is about personalized pharmacotherapy, about precision medicine. How do we personalize pharmacotherapy? So let's see these scenarios. Like, for example, Alexa was hospitalized for a brain bleed in the hospital and developed ongoing seizures despite the escalating doses of the anti-seizure medications. So like patients develop seizures. We started anti-seizure medication, still seizing. Although the anti-seizure medication is still supposed to be appropriately dosed, but they keep increasing the dose, patients still seizing. Of course, this could be disease progression, but also this could be the medication becomes ineffective in this patient. Another example is George. George takes at home lithium for bipolar disorder. And when he got admitted to the hospital for spinal cord injury, while in the ICU, they developed a very high sodium levels, which is actually a side effect of lithium. But like the patient was fine at home, but why did it become toxic when they come to the hospital? It looks like there is a pharmacotherapy variability within the individual as well. And the last example is Hassan was hospitalized for brain injury, and he developed a lung infection while in the ICU. and he did not improve with the recommended antibiotic treatment. So like develop an infection and we started appropriate antibiotic that works for the patient. However, the dose, like the patient developed a treatment failure. Why this is happening? So like by looking at the big picture, let's say a patient admitted to the hospital with a diagnosis A, and they have a past medical history of a disease B that's treated with a medication. On admission, they got medication M2 to treat the new diagnosis, and M1 actually takes it home. And what happened is M2 is that didn't work, similar to anti-seizure medication, and M1 caused adverse reactions. So, so the change of the efficacy of the medication, this is called pharmacotherapy variability. So what's the pharmacotherapy variability? Pharmacotherapy variability, it's a variability in medication response among and within the individual that's attributed to the inter and intra-individual differences in the action and disposition of drugs or differences in the pharmacokinetics and dynamics of drugs. So this means that there are some factors. When the patient was at home, they take a medication, they are happy and tolerating it. But when they become admitted with a brain injury, for example, the medication became toxic. And understanding the factors that leads to that will allow us to actually personalize the treatment for those patients. So my overall research that I do is to study those factors that contribute to pharmacotherapy variability and translate bench-side and bedside observations into clinical practice protocols that will potentially improve the outcomes in the acutely ill patients. When I say acutely ill patients, but like why I'm focusing on acutely ill patients? First, as a definition, acute illness means unexpected but not life-threatening health condition, such as injury or infection. There's also something called the critical illness. It's unexpected but life-threatening. Patient may die if you don't get treatment in the intensive care unit. And critical care involves many life-saving supportive modalities that maintain the life of the individual, such as mechanical ventilation, artificial breathing machine, use of vasopressors, and so on. Okay, but why do I focus on those acutely ill patients? Because acute illness adds extra layer of complexity contributing to pharmacotherapy variability. I'll show you that. And this might lead to therapy failure or adverse drug events that can have a major adverse consequence. So in the ICU, for example, we often need to make quick decisions. And without having those decision-making algorithms, tools that help us make decisions and tailor the treatment for those patients, the decision might be too late. Like, let's say if a patient dying from an infection and we give an appropriate treatment, that would be a big issue. So how do I study that? So like I'm providing here the example of a neurocritical care patients. So a patient comes to the hospital with life-threatening neurological injury. So when you look at the patient is actually a neurocritical care patient is a patient who is critically ill and they have a neurological injury. And so if the patients, like there are multiple factors, everyone has different genes, right? And this pharmacogenomics will affect the response of the medication. The history of the individual, the socioeconomic factors. When the patient is critically ill, they might need mechanical ventilation, vasopressors, like call it co-interventions. Those co-interventions might affect the physiology and the pharmacokinetics and dynamics of drugs. In addition to that neurological injury, might also add to it, like similar to the critical illness. So this is like different layers of complexities. So I summarized that into a neuro-CPK wheel. The neuro-CPK is the name of the lab, which are the factors contributing to pharmacotherapy variability. The good thing about this wheel, it can be applied in all other disease states, not only for neuro patients, but I'm providing neurocritical care patient as an example. So as you can see here, starting from here is a comorbid conditions, top right here, comorbid condition followed by drug disease interaction, drug-drug interactions, drug-food interactions, practice variations between different hospitals, actually to variation in the action of drugs. Patient characteristics, the age, sex, race, the body mass index, socioeconomic status, social history could affect how medications work. In addition to that, the genes of the individual as well, right? The pharmacogenomics. And the last thing that we do in the ICU and acutely ill patient, the co-interventions, the things that we do to the patients. Let's say if we do fluid resuscitation, this will increase the volume distribution of drugs, because adding lots of fluid might affect how the medication work. Renal replacement therapy, dialysis removes medications. And this we need to take into consideration. So by identifying all these factors, we'll be able to shift our paradigm from one size fits all medicine to stratified medicine by identifying different groups that respond to medication, to precision medicine, which is like a treatment that's individualized to the patient. And this is the future of medicine. The future is actually combining all the data together. Instead of studying only one thing, by combining all the data, genomic data, radiomic data, clinical data, metabolomic data, all these pharmacotherapy variability data, and now we are in the era of artificial intelligence, this could be actually contribution for a decision tools. Like once the patient gets admitted to the hospital, based on the patient characteristics, we'll be able to decide what treatments the patient should be on. Still some work need to be done in this area, and this is the future of medicine, personalized medicine. And pharmacists play a role in there because they are the medication experts for pharmacokinetics and dynamics of drugs. So pharmacotherapy variability is a potential contribution of therapy failure, adverse reaction, or failure in drug development. Studying the additional layers of complexity in critical care and epilepsy will guide precision pharmacotherapy in those populations and also in other conditions as well. So we can eventually will have the right drug for the right patient or the right dosage regimen, leading to better outcome. So in conclusion, pharmacists are essential contributors to personalized, safe, and effective patient care, especially in complex fields like neurology, transplants, and others. By strengthening our clinical roles, collaboration across professions, and using evidence-driven personalized approach, we can significantly improve patient outcomes across the globe. Thank you.
For your insightful presentation about the evolving role of pharmacists in personalized pharmacotherapy in Canada. Mr. Sharif Mahmoud, we will now proceed directly to the presentation by our next speaker. We look forward to reconvening with you during the dedicated question and answer session following this next segment. Thank you. Okay, ladies and gentlemen, a quick reminder that question and answer session will take place after the second speaker. Please hold your question until then. We will now move on to our next speaker. Okay, it is my pleasure to introduce our second speaker. Joining us from Australia, without further ado, let's get started. Please join me in welcoming Prof. Bandana Saini. Hello, Prof. Bandana Saini.
Hello, everyone.
Hello. It's a pleasure to meet you, Prof. Bandana.
Same.
Okay. How are you?
I'm not too bad. I'm very delighted to be at this conference, and I already enjoyed listening to the last end of the talk by Professor Sharif.
Okay, wonderful. Thank you for joining us, and we truly appreciate your time. Before we begin, please allow me to read your curriculum vitae to our participant. Prof. Bandana Saini is a senior lecturer at the Sydney Pharmacy School, Faculty of Medicine Health, University of Sydney. She received her graduate certificate in higher education and graduation certificate in implementation science from the University of Sydney in 2007. Her research area focused on implementing and evaluating several successful pharmacy-based models, including screening, patient self-management, and clinical audits, as well as pharmacovigilance. On this occasion, Prof. Bandana Saini will provide valuable perspective on innovative pharmacy service models for respiratory disease and on strengthening the pharmacist's role in primary care. To our participant, if you have any question, please either raise your hand or submit your question via the Zoom chat or the YouTube comment section. Question will be addressed during the question and answer session at the end of the presentation. Prof. Bandana, you have 30 minutes for your presentation, and then we will continue with the question and answer session. May now begin, Prof. Bandana?
Yes, certainly. It's my pleasure to begin. I just want to check that my slides are displaying correctly in full screen mode.
Okay. Okay.
And are they on your screen?
Huh?
Yep.
Okay. Okay. The screen is yours.
Lovely. All right. And I'm presuming everybody can see the slides well. Okay, well, I'm going to talk about breathing life into the role of pharmacists in respiratory health services. And really, obviously, I'm going to be presenting from the Australian perspective. So you might ask me the first question, why would we be interested in respiratory conditions? And this is just some data from WHO, the World Health Organization, that shows us that, there's more than 260 million people in the world who have asthma, and nearly 500,000 people die from asthma each year. And importantly, a lot of these deaths are actually in low to middle income countries. If we look at COPD, which is really chronic obstructive pulmonary disease, we know it's the fourth leading cause of poor health worldwide and about 3.5 million deaths over the whole globe. And importantly, again, more than 90% of these deaths are really happening in low to middle income countries. So this puts it into perspective why, these conditions are important. Because I'm going to be talking a lot about community pharmacy services in Australia, I'd really like to show you the Australian healthcare system and what community pharmacy looks like. So we have about 6,000 community pharmacies compared to the 30,000 that you have recorded in Indonesia. Our population is 27.2 million people compared to yours, which is closer to the 290 million. But our community pharmacies are quite accessible. So even though we only have that number of population, there are about 450 million individual patient visits to a pharmacy that are recorded each year. And of course, pharmacists' core role was, is, and will remain medication supply. But we do have a very expanding scope of practice, particularly now in the last year or so, where we're moving on to roles in prescribing medicines. We now have a government-approved role in working in aged care homes, so a lot of older people. So our population is much more older than the Indonesian population on average, and many of our older people live in aged care homes. And now pharmacists will have a role to play in those settings. And of course, we are one of Australia's top 3 most trusted professionals after nurses and doctors. And certainly, if you look at respiratory, there are a lot of respiratory conditions that pharmacists manage on an everyday basis. So that was about community pharmacy. Now, if I may quickly go through what the Australian healthcare system looks like, so you can compare and contrast with the Indonesian healthcare system. So Australia has a tiered healthcare system, which means that we do have like a primary care level, a secondary care level, which is outpatient clinics and hospitals, and a tertiary level, which is of course highly specialized, hospital clinics or specialist clinics. Like Australia, like Indonesia, we also have universal health coverage, and the name of our system is called Medicare. Now, as part of Medicare, you would have medical services that are funded by the government. So, for example, general practitioners or family physicians, a lot of their fees is covered directly by Medicare. So, a patient can see a GP or a family physician and not have to pay for that service. Medications, if they are listed on the national formulary called the Pharmaceutical Benefit Scheme, then these medications are also subsidized, but there is a co-payment that is required by the patient. So as an earning member of society who is not on any benefits, I would still be paying around $33 for my medication, even if I'm using something as expensive as a biologic, which actually might cost $1,800 per month, but I'm paying $38. And based on the income tax that I pay and the Medicare levy that I pay to the government, this is what allows the government to support people's medication use. And people who are on a pension or have some disability or are unemployed may be able to access the same medication instead of paying $30 at a much lower rate of about $7 as well. The hospital coverage is also included as part of the universal health coverage, but that is through a state budget. Pharmacy in Australia is very regulated because the prices that a pharmacist can charge for any medication that is on the PBS scheme are set. So if I go to a pharmacy in Sydney versus going to a pharmacy in Darwin, that price for that medication has to be the same. If we look at medical services, there are only a few medical services that are listed on the medical benefits schedule that pharmacists can provide at the moment. But we believe that this is going to change quite quickly. And these services that are listed include medication review, whether that's done in a patient's home or it's done in an aged care facility. So now going back to the respiratory conditions, and just to put it in context, what might you consider as a pharmacy service would be any action that's taken by a pharmacy or organized by a pharmacy. So a pharmacist or a pharmacy don't have to deliver the service themselves, but they can authorize it. And it requires the application of specialized knowledge, whether the pharmacist does that directly or through an intermediary, or it's provided to a patient or a client or their agent. And the idea is that we're improving health and adding value to the healthcare delivered. Pharmacy services might be of different varieties. So as I mentioned, some that are supported by the government. So I've listed the medication review that I already explained. Some might be covered by individual states or in local area health services. So for example, we do have pharmacies that sit with general practitioners, but that is not funded by the central government. It's coming from a local area. Of course, we do a lot of research, and our research for service evidence around pharmacy services is what feeds into developing new medical benefit schedule items. And of course, pharmacies, community pharmacies are businesses, so they might offer some services that is within their scope of practice on their own as entrepreneurs. So for example, measuring blood pressure or doing lung function testing, or even doing home sleep studies. So that involves, a monitor that measures your EEGs when people have a sleep disorder and things like that. They do it on their own, but, it's within their scope of practice. All right, now I'm back to the respiratory conditions. So I think everybody knows what asthma is. It's a chronic obstructive lung disease. It's curable. It's not curable, but controllable. And I think it's important important, even though this talk is not clinical and it's not about just asthma, I'd like to highlight that we have really uncovered some very interesting things about asthma in the last 20 years. One is that it occurs as a result of gene-environment interactions that might, start even whilst a child is in utero. And how the environment around the child, even when they're in utero, might shape the shift in the immune system towards a more allergic type profile. So what we say is that normally your cell-mediated immunity comes through Th1, T helper 1 type cells, or Th2 type cells, and the Th2 type cells are your immune cells. They usually mount an allergic kind of response. And we have gone to a level where we can really understand individual cytokines, for example, interleukin 5 or interleukin 4 and interleukin 13, that play a role in the pathophysiology of asthma. In other words, we do have biologics which can now target these specific interleukins as well in very severe asthma. So really the landscape of how we treat asthma is now changing. And though I said it's not curable, with these new biologic treatments for severe asthma, it's almost, you can actually have remission. The other thing that's interestingly changing in asthma is the prevalence patterns. So even though many years ago, like decades ago, Indonesia may have been classed as a country with low prevalence of asthma, but there's now a shifting nature where prevalence of asthma in high prevalence countries, which were usually the English-speaking westernized countries, is actually falling, whereas countries which were previously classified as low prevalence, such as Indonesia, the prevalence is actually on the increase. So it's something to consider. Australia is the world's asthma capital. So I think we have one of the highest prevalence rates of asthma in the world, 11%. And of course, there's, despite being, a developed country, or that's what we think we are, there's still about 500 people that die from asthma each year. So this is the data from 2024. It's a very costly condition as well. And there's more impact of asthma in the urban areas. And of course, a lot of Australia lives in urban cities. And interestingly, people who are born in Australia are twice as likely to have asthma compared to people who were born overseas. So I have asthma, even though I was born in a different country, but it's a very interesting pattern to observe. The other condition is COPD, which is really a chronic lung condition as well. And it has unique symptoms like dyspnea, breathlessness, cough, and production of sputum or phlegm. And exacerbations. And it also occurs due to abnormalities of the airways. And this often, unlike asthma, where some of that airway obstruction is reversible, but in COPD, it's often quite irreversible because the airways are completely obstructed. And our current understanding of COPD is that it may come from a range of different reasons, lung development, genetics, environmental exposures, infections, for example, TB in childhood could predispose you to COPD, overlap with asthma as well. And of course, there might be some that we don't know as well. And of course, the aging lung, you have declining lung function already. And often, COPD is diagnosed in people who are over 40 years of age. So the prevalence of COPD in Australia is quite high comparatively, 7.7% for people older than 40 years. But importantly, 50% of COPD is diagnosed. And of course, it imposes a hefty burden of disease in Australia. 90% of people with COPD also have another condition. I'll describe another condition which is less talked about, I think, in pharmacy, and that is obstructive sleep apnea. Apnea means stopping breathing, and sleep apnea means you stop breathing when you're asleep. It's only a very, very microseconds of where you stop breathing, because otherwise, if you really stop breathing, you wouldn't be alive. And the risk factors are being obese, male gender, older age, risky lifestyles such as smoking or alcohol use. And the symptoms are, of course, snoring. It doesn't mean everybody who snores has sleep apnea, but a lot of people with apnea would snore. Fatigue, mood, lack of, now, if you're waking up so many times at night, you do not have refreshing sleep, so you cannot pay attention next day, and your entire resting metabolism at night, where your body is meant to rest, is now not resting, and therefore you have a lot of other cardiometabolic issues as well. Again, obstructive sleep apnea is heavily underdiagnosed. So very quickly, I'll take you through some of the research that we've done. Disease state management for asthma. I've been involved in this work since my PhD days from 1998 to now, where I'm leading large grants. And the general idea has been that you would identify patients who don't have good asthma control. You would assess their adherence and inhaler skills. You would understand, what interventions you can provide as a pharmacist, provide asthma education, sit with the patient and set some goals with them about their own asthma, follow these patients up at regular intervals, document all the interventions you're providing, and communicate with doctors. And this is just a snapshot of showing you that in the old days when we did it on paper, now, of course, this is all digital. But, this is how you would ask someone about their adherence. So, does the medication bother you? Or you would ask them about problems in their adherence. And then you would document whatever you felt were issues in the patient's asthma. And then you would use this documentation to refer that patient to the GP. And this is how you could set goals with the patient. You would ask them to think about, how they would like to improve their health and, what sort of goals would they set, what might be the issues they would have in achieving these goals and strategies to, manage those barriers. So this is just evidence. It's not about the numbers, but this is one of the nicer projects that we did. We had nice results. So this was the Pharmacy Asthma Management Service that was funded by the Australian government. We had 100 pharmacists. Remember, we only have about 6,000 pharmacies. So we had 100 pharmacies that were, engaged in the study, and they were all the pharmacists in these pharmacies were trained. They recruited around 600 patients. About 400 patients completed this trial. And for these 398 patients, pharmacists recorded 24,000 interventions that they delivered. And these patients, set about 1,800 goals over 6 months. And just to prove a point that when we looked at asthma control, you can see that, this nice orange color is for good control. And if you look from, baseline to the final visit in both groups, so we had a 3-visit arm and a 4-visit arm. In both groups, this proportion has significantly increased. Similarly, if we looked at inhaler technique at baseline versus final in these people who were part of the study, you can see this dramatic improvement from 17 to 47 or 14 to 67%. Similarly, if we look at non-adherence, the levels of non-adherence, with the score that we were using, really fell as well. And the study showed that all of these improvements in, for example, asthma control were cost-effective. When we looked at what pharmacists thought about these studies and what patients thought, so patients really valued the pharmacist's input, and pharmacists also felt a high degree of professional fulfillment when delivering the pharmacy asthma management service. So I leave you with that thought about what pharmacists can do in asthma. I'm going to show you an example from COPD. So as I said, COPD is a growing cause of morbidity, and early screening and detection of COPD is encouraged because a lot of COPD is underdiagnosed. And we know globally that pharmacists can screen for COPD. So we actually did a study in this state, in New South Wales, where we designed a protocol where, pharmacists would put posters in the pharmacy, and, people who had cough or producing, phlegm or sputum could, identify themselves as, wanting to do lung function testing. And then we had some questions that asked about their symptoms. They asked about their, repeated history of, infections. And then we used this really small device, and I'm hoping the camera can pick this up. And this is called the Pico 6. So this is not full-blown spirometry. It is only measuring the forced expiratory volume in 1 second divided by the forced expiratory volume in 6 seconds. That gives you a good indication of, is there a lung function abnormality when people expire? And you can see that there's 3 zones, the red, yellow, and green, that the pharmacist can easily see. So this is what the pharmacists were actually doing. So we really had about 20 pharmacies in our state, New South Wales, that were trained. They recruited 167 patients. And these 167 patients who were able to complete the lung function test. So you actually have a mouthpiece that goes with this device that can be used, disposable mouthpiece. And so it showed that of those 157 were able to do the test with this device. 25 were in the red zone, 36 were in the moderate risk zone, and 96% were at low risk. And so most of these patients in the high risk and moderate risk were referred to the GP. And, we followed these patients up and we had a diagnostic yield of 10%. So about 15 of those 157 were actually diagnosed with COPD. And we also had 8 people diagnosed with other condition as well. So it means that the results indicate that pharmacists are really able to facilitate the early diagnosis or early pickup of COPD in their communities. And this is just the paper that was published. And also, not only have we done screening work for COPD, we've also looked at pharmacist roles in providing disease state management and being able to decrease the exacerbations that COPD patients often experience. The last case study I have is for sleep apnea, where our project aim was to implement a screening program that involved patient and pharmacist education to see if pharmacists could pick up sleep apnea. And in this study, we had a device called a nasal flow monitor. And we wanted to check whether just using a questionnaire or a questionnaire with the nasal flow monitor. So if you stop breathing at night when you're lying down, there will be no flow of air in and out of your nose. And that's what the nasal flow monitor would pick up. And these were some of the validated instruments that we use to check people's risk of different sleep-related, sleep disorders. Just to show you that, we have to really use well-known instruments that you can have a good score and a cutoff to say this person is at risk and this person is not at risk. We did this digitally as well. And so the process was that we recruited pharmacists in New South Wales, one state. And we, then trained these pharmacists, and then the pharmacists recruited patients. Patients had to be adults and not have a prior history of diagnosis of sleep disorders. They then used the screening questionnaire that I just showed you some of those instruments. And in this arm, the risk assessment plus nasal flow, they sent the patient home with the nasal flow device to be used for 3 nights. And then pharmacists completed the scoring, and anyone who was at risk was referred to the doctor, to the GP, and then we as researchers followed the patients up at 12 months. As well. This is to show you the digital version where pharmacists could simply, very quickly tick through the questionnaire. And this is to show you how the questionnaire auto-calculated the risk scores for patients. And so it also generated a letter for the GP, which explained the patient score and what the score actually meant as well, so that pharmacists had less work to do. So this was a study where we had 325 patients in the 2 arms, mostly older and, 50% male, roughly 50% male, female. And there was quite a high level of risk as well. So these are just the risk scores for each of the individual questionnaires. And the screening took around 10 minutes, 11 minutes. So this is how the pharmacists had posters in their pharmacies to attract patients to talk to them about doing the sleep screening. And in the 2 arms, as I showed you, we had 12 and 11 pharmacists, 325 and 333 patients admitted, 152 and 173 who completed, and 82 of these patients, if this doesn't add up to 82, it adds up to more, but people might have been at risk of more than one sleep disorders. So these patients were then referred to the doctor. We followed them up. And not all patients could be followed up. So 125 of 152 and 155 of 173 were followed up. But when we talked to patients who had been referred, only about half remembered that they had been referred. And only, a proportion of them had actually accepted that referral by going to a doctor with that referral. And there were 23 patients who were diagnosed out of the 325 that were screened. And there were a lot of other interventions that the pharmacist recorded. So besides the referral, providing information, counseling people about their sleep health as well. And the patients really found, apart from, the diagnostic yield, The important thing was that a lot of patients were really happy with this screening, and 52, half of them were even willing to pay out of their own pocket to get this kind of service. And many of them reported actually changing their behavior after the pharmacist education. And these are just some comments about, they found it helpful to even know they had a sleep disorder or to rule it out that they didn't have a sleep disorder as well. So I would conclude that Australian community pharmacists can successfully deliver a wide variety of interventions that may range from screening to health education to chronic disease management, and that these services lead to both professional and patient satisfaction. And you might question me and say, are these now in practice? Now, these models are partially in practice. So there is an asthma prescribing, a model that has been subsidized by the Queensland state government. And also pharmacists have taken some of the provision on an entrepreneurial level. So they're using these protocols to deliver services because there's evidence for them. Coming to Indonesia, so we did talk to about 103 pharmacists in Yogyakarta or Jogja, and understood that, pharmacists were willing to do a lot more than they are, but they just felt that they didn't have the structure or the right sort of training to be able to provide these kind of services. So then I looked at what your respiratory researchers are saying in Indonesia. And respiratory researchers feel that, there is a relatively increasing prevalence of asthma, 4.5, less than Australia, but still there, and COPD, 3.7. This is probably more than Australia because this is the overall prevalence, whereas the 7.7% I showed you earlier was for people over 40. The important thing about Indonesia is that there's a very high level of risk exposure. So this particular researcher, two researchers, they show us how, this is a person on a street, maybe cooking satay and, getting exposed to a lot of oil and, fumes from the cooking. This is a construction worker who's being exposed to construction dust. That can lead to COPD and other problems, and there's not much protective, equipment being used. And this is a housewife who is in her home cooking a meal, but she's using biomass fuels, which are actually one of the risk factors implicated in COPD. And so these researchers said that there's an evolving landscape of health, and it's imperative to implement public health strategies that address not just TB, but also the non-communicable diseases. And it's important to prioritize early detection and preventive measures. So I haven't practiced as a pharmacist in Indonesia, but, I do think, having talked to those 103 pharmacists, that Indonesian pharmacists can really enact similar models that I showed you from Australia. But probably some of the, processes and structures need to change. So probably at the training level, a much bigger focus on, patient care and patient-facing roles, counseling patients, assessing patients, doing things like lung function testing with patients. That's really important. And also improving pharmacist-patient ratios. So I think even though you have a 284 million population, you only still have, a low number of pharmacies and pharmacists. So comparatively, that ratio needs to really be improved. And this has also been published by the Federation of International Pharmacists as well. And academics need to do this kind of health services research. So there's a lot of scientific research in Indonesia, but about health services and how health services can improve health outcomes for patients. And I know that there are, rules and standards in Indonesia about pharmacy practice and the Pharmacy Practice Act and the Ministry of Health regulations, but probably stricter, application of those rules. So for example, in Australia, only pharmacists can own a pharmacy. So you're always front and center of what's happening in that pharmacy. We also have a minimum award rate. So, whilst owners can pay their employee pharmacists what they want, but they always have to pay above a minimum level. So, that encourages everybody to, work in a professional space. You also have, the Puskesmas I might be pronouncing it wrong, but there has to be a better uptake of having pharmacists in these primary healthcare centers. Also, very few pharmacists have affiliated themselves as contractors or suppliers within the Universal Health Coverage Scheme. So you need to have a bigger presence of, PharmD or P-Farm pharmacists in these services, UHC as well as Puskesmas. And maybe using the Gamma chairmat. This is your quality use of medicines campaign. So it's only a campaign, but you can use this campaign to really, spring off a lot of roles for pharmacists in different settings. So needing to make sure that pharmacists are key players in this Gamma chairmat. Also, you do have a wide range of professional organizations. We really need to have these organizations working closely with the Ministry of Health so that there is advocacy for increasing the pharmacist scope of work, increasing the standards, that we expect from, community pharmacy-based services. And of course, many of you here are researchers, so I've already said you probably need to build that research evidence base, but also students to be advocates for what pharmacy can do. So in conclusion, Indonesian pharmacists, I think, can certainly enact the same kind of disease management services as in Australia for respiratory conditions. But probably what you need is what is known in the literature as a Kaizen approach, and that's kind of Japanese, concept. And I don't know Japanese, but I think it means good change. And it means that you really need to make small changes at a time. If ambition is too high, we'll completely change pharmacy practice in Indonesia. That would be much more difficult than making small changes. And in Australia, what we did was in COVID-19, we started vaccinating, and the government saw they needed more people to vaccinate. Now, suddenly, all of us are allowed as pharmacists to vaccinate. And on top of that, we're saying, well, we had to supply medicine during COVID, so we need to have some prescribing rights. And slowly those rights are coming up as well. So we need to make small changes at a time and document what the impact of those changes are and really publicize the roles that we are playing and the difference that these roles are making in our society. And then making sure that these small changes are actually embedded in practice before moving to the next big change. So those are obviously, I've worked in this area in health services research and pharmacy for nearly 3 decades. So this is my thinking. Doesn't mean that it's the correct and only way forward, but certainly some food for thought. I would really like to acknowledge all of the different bodies that have constantly funded research that I've presented to you, including the Pharmaceutical Society and the Pharmacy Guild, all the patients and pharmacists who have been part of my research, as well as a range of colleagues, particularly Professor Carol Moore and Professor Inez Grass, who were my PhD supervisors. And my last meaning is to say, when you can't breathe, nothing else matters. So respiratory health and using pharmacists to improve respiratory health in the community is a very important game.
Okay, thank you, Prof. Bandana Saini, for your insightful presentation about breathing life into the role of pharmacists in respiratory health service, the Australian experience. We will now proceed to the question and answer session for both our speakers. Dear participant, we are now entering the first question and answer session, which is dedicated to question for Mr. Mahmoud. You are welcome to ask your question directly by using the raise hand feature. Once again, we open the opportunity for participants who would like to ask their question directly. Okay, all right. We already have several questions in the Zoom chat. Mr. Sharif Mahmud, are you with us? Okay. Okay. Okay.
Hello. Hi. Yeah.
Yeah.
So
So,
I couldn't
okay, we
unmute
have
myself.
a question for you,
Yeah.
Mr. Sharif Mahmud.
Yes.
Okay.
Yeah. I saw few great questions in the
Yeah.
chat. I
Okay.
also wanted to mention.
Okay.
Yeah. I can go over the questions if you like.
Okay. I will read the question for you first.
Okay.
The first question is from Maria Yangshe Lenggu from Poltekkes Kemenkes Kupang regarding what is the role of researcher from pharmacy school or researchers in collaborating with clinic to address health issue in Canada. Could you explain this with the direct example?
Yes, this is a great question. So
Okay.
actually, the role of researchers, like there is an ongoing research across all the Canadian institutions to solve health issues. So like we actually the research that I'm involved in and similar other researchers called translational research, and also from bedside to the lab and then back to the clinic. So there is many research issues in the clinic actually brought back by researchers to do this research in order to bring it back. So examples of that, for example, in the ICU that I'm practicing in critically ill patients, when they give them medications that are renally eliminated, they see like lots of medication failures because there is a new phenomena like that's just recently described called augmented renal clearance or super kidneys. And but the issue is the current practice, the current creatinine clearance equations did not really detect those, underestimate the true prevalence. So this is one of the questions that I brought back to assess what is the best way to detect augmented renal clearance. Other examples, like for example, stability studies. So there are some expensive medications that patients are getting, and they have limited manufacturer stability. So when you give it to the patient, like for example, especially for kids, where there is an intravenous medication, and they give like quarter of a bag, and then they throw away the rest because the stability is limited to like 8 hours or something. So what they do, they ask like a pharmaceutical sciences scientist to see like will this medication have an extended stability? Can we test it beyond the 8 hours? And we did that, like in our University of Alberta. We had few examples that we found that some of those medications have extended stability, and the great impact of that is actually reducing the healthcare cost because we can use the medication for a longer period of time. There are many other examples in clinics, in management of chronic illnesses, hypertension, diabetes, and others that people actually take issue to address some health-related issue through research. That's the answer to the first question. Thank you.
Okay. Thank you for the question and thank you, Mr. Sharif Mahmud, for your response. We will now open the next question coming from Elina Nurcahyo from Unjaya regarding can schooler be considered sufficient for a safe health assessment given that it focuses solely on symptom and does not explicitly include vital information regarding allergy history, current medication, and pre-existing medical condition? Furthermore, how is the acronym adapted to address the challenges when communicating with vulnerable patients or those who struggle to describe their symptoms?
Yeah, this is a great question. So there are two parts to that question. The first part is about the tools that I presented, like Scholar, 2CAs, and so on. This definitely should be combined with full medical and medication history of the patient, right? What I meant about like using the Scholar tool is to identify the patient's symptoms, identify what are the aggravating remitting factors, identify any red flags that warrant referral to the doctor. However, when you assessing that, you need to assess that in concert with the patient past medical history, demographics, socioeconomic status, social history, and others, also medication allergies, uh, to have a full assessment, because when you do the assessment, the next step is to actually do a plan. And if you want to do a plan, let's say suggesting a medication for that patient, you suggest it based on the patient characteristics, because some medication could be safe for others or could be unsafe for others. So yes, definitely we include all these factors when assessing the medications, and these tools are just meant to supplement the main medical and medication history. So the other part is about the patient with communication challenges. Definitely, there are tools that can help pharmacists to, depending to communicate with patients, depending on the patient needs, right? So if it is the issue, like I tell you, like in my practice in the ICU, and many of those patients are actually on an artificial breathing machine and they cannot communicate at all. So like, how do we care for them? Well, and those challenges could be like language barriers, right? And could be understanding, or maybe the unable to talk or see or something like that. So there could be tool that could be very helpful, like visual aids, could be written communication, or talking to the involving caregivers of those patients. So there are actually tools that support this part related based on the patient needs. And one of the things that we do in communicating with patient also is to the teach back approach. Like, so once we finish, we also need to assess the understanding. The communication is not only related to physical barriers, could be also patient understanding. So asking the patient, can you repeat, okay, so what do we now, how are you going, can you tell me how you're going to take this medication? So teaching back to making sure to address to see if they actually get the point, and are able to safely and effectively take the medication. Great question. Thank you.
Okay, thank you for the question, and thank you for Mr. Sharif Mahmoud for your response. We will now open to the last question. It is from Nico Unjaya regarding Mr. I'd like to ask about the current state of pharmacogenomic implementation in personalized medicine in Canada. To what extent has it been integrated into clinical practice? And are there any national framework or institutional initiative currently driving its adoption?
Pharmacogenomics, this is a great question. Pharmacogenomics is a vital tool for personalized medicine. It's really needed. Evidence is growing on that. And anyone in the field will say like this is going to be very helpful in practice. However, it is progressing. Like there is pharmacogenomics implementation and adoption in Canada, but it's still, there is a long way to go. Because there are some barriers, right? It's one of those barriers is having decision tools for and prescriber education, healthcare education. Because like when someone do a pharmacogenomic testing, just say the patient is a fast metabolizer for this enzyme. Okay, what does it mean to me as a clinician, right? Does this mean that can I prescribe this medication versus I don't prescribe that medication? There are some websites, there are some decision tools actually built in some pharmacy now. We did research in Alberta about adoption of pharmacogenomics in clinical community pharmacies. and it's proven to be very useful. There's a manuscript in preparation on this as well. One of the main barriers as well is the reimbursement issues, the cost. Like currently, patient has to pay to do the pharmacogenomic testing. It's not covered by the insurance, and this is a big barrier, right? But I would say, like in the future, pharmacogenomic will be an essential part. And any patient currently, any patient who did pharmacogenomic testing, this is built in their electronic health record. So like they have practitioners have access to that, but we're still missing the decision tool and prescriber education. Thank you.
Okay, thank you, Mr. Sharif Mahmud. Okay, Mister, we still have one more question. Is it okay?
Yes, of course.
Okay, I will read it for you. The question is from Mimik Andika from Universitas Fort de Kock. The question is, currently, what diseases are being extensively researched by researchers team in Canada, and what are the most common outputs from this research result?
Great question. So actually, if we're talking about Canada wide, I would say almost all disease states like being investigated. The researchers with expertise in multiple areas, and there are lots of findings coming out of that. Those findings could be primary literature research finding, and also the implementation of these research findings now being incorporated in Canadian guidelines for multiple disease states. So I cannot really pinpoint a specific disease state because many of the disease states are being tested, are being researched. And I believe this could be the case in multiple other countries as well. So if there is no specific disease that I could say, but like there's research in diabetes, hypertension, asthma, critical care, and many others. Transplant, they're pioneering transplant research specifically here in Alberta, specifically islet cell transplant for diabetes research. There are many others in Canada, but like I would say that there is federal funding to support mitigating health care issues and disease states. And not only to support disease states that are in Canada, but actually globally as well. We have the Canadian Institute of Health Research, and does have multiple sub-institutions under that. And those institutions dedicated to specific conditions, cardiovascular, neuro, respiratory, and others. Yeah.
Okay, thank you very much, Mr. Sharif Mahmud, for your response. For the valuable insight and for addressing the participant question.
Yeah.
Okay, dear participant, we are now entering the first and the second question and answer session, which is dedicated to question for Prof. Bandana Saini. You're welcome to ask your question directly by using the raise hand feature.
I think I already see some questions. Would you like to read them out, or do you want me to read it out?
Okay, I will read the question. Prof. Bandana Saini, we already have several questions in the Zoom chat. I will read it for you first. Okay, the first question is from Mr. Aska regarding your research show that community pharmacy role can involve not just as medicine vendors, but also conduct preliminary clinical assessment in some capacity. May I ask how this idea of clinical assessment is responded by other medical profession, in particular from our MD colleagues? Yeah.
Thank you. That's a very, very pertinent question. So I think it depends upon the role that the pharmacist is playing. So, for example, we do have a lot of medicines that are available without a prescription in the pharmacy. For example, your eye drops for conjunctivitis or ear drops for otitis, etc., etc. So for decades, our medical colleagues are used to us, doing this preliminary assessment of the patient has conjunctivitis, has otitis, providing a medication and or referring. But I think when you take on a bigger role where you're looking at a chronic condition like asthma or obstructive sleep apnea, or I'll give the case study of obstructive sleep apnea. So when I started doing that research in 2005, OSA was not a very well-studied condition at the moment, and sleep specialists, so these are not just your family physicians, but even specialists who are very worried about what pharmacy was doing. So what we did was collected the evidence on the quality of services provided. We then brought together the Australian Pharmaceutical Society, so Pharmaceutical Society of Australia, PSA, as well as the Australasian Sleep Association. We made them sit together at a table and showed what pharmacists were doing. And the outcome of that was that we were probably the first country in the world to have standards of practice for the provision of sleep apnea services. And I think that having those standards of practice then, really allowed confidence in what pharmacists were doing in general. And, there's a lot more acceptance. Now, my sleep specialist friends actually ask me what pharmacy is close to their area that supplies CPAP. So we have about 6,000 pharmacies, and about 1,000 of them actually supply CPAP machines and do sleep studies. But the contingency is that they have to follow the standards of practice. I think with the asthma and COPD work that we've done, it depends upon the relationship that pharmacist has built with their regular family physician or general practitioners, as we call them, in their area. Some of them have very good existing relationships, and these relationships are probably much better not in the city areas, but in the regional or rural areas where there's a smaller population. But it's a matter of building that relationship. And what has served this entire purpose is to really do research, to provide evidence that, is high-grade evidence to suggest that pharmacist roles are clinically and cost-effective, being able to present these at medical conferences. And now we do have many more medical colleagues in hospitals, as Professor Sharif has already pointed out, that there's already a growing role for pharmacists, and they're very well trusted and acknowledged in the hospital setting. But in community pharmacy too, now with this increased number of inhalers, a lot of GPs call when I occasionally work in a pharmacy to ask for advice on which inhaler is better for my patient, because I'm better able to provide that, evidence. So I think that there is a slow increase in, attitude towards accepting pharmacist services. And what has also helped is that a lot of our teaching, not all of our teaching, but some of our teaching is now done interprofessionally. So the medical students, nursing students, pharmacy students learn certain concepts altogether. So I think at a community level, at a systems level, you have to, spend time to invest in doing this research, making these changes in curriculum and education for that level of acceptability to grow.
Okay.
I can move to the next question.
Yes, we still have more questions, Prof. Bandana.
Yeah. So this is a very nice question about patient adherence and written action plans. So even in Australia, what we are now moving to, so my last project that I showed that we are doing is to have action plans, but to really be able to remind the patient using text. And in Indonesia, I know WhatsApp and a whole lot of other applications are popular, and it would be smart rather than having paper-based, action plans, to actually be able to have a digital system to send these action plans and reminders. So as I said, I have asthma. So on my phone, I have an app that's linked to my pharmacy. And that app reminds me when my refill is due and if it's overdue. And it also sends me messages like last week, there was a storm in Sydney. And it said, Pandana, please note there's a thunderstorm in Sydney. Stay indoors, wear a mask, and all of those things. So I think we have to use platforms that are not just actual face-to-face platforms, but also use technology that our patients are already using to help, adhere to an action plan, remind them of the action plan. You also asked a question about logistical barriers to achieve high adherence rates. Yes, I think that the number of pharmacies and the number of pharmacists in these government-funded primary care centers is quite less. So I'm not sure who is providing that adherence support service to patients. Ideally, it should be pharmacists because we understand how medicines are to be used. So improving those ratios, it might take 5 years, but that's an important, thing that might actually be a game changer. Pushing some of our private, community pharmacies. So I believe 70% of Indonesian community pharmacies are privately owned and owned by non-pharmacists, and changing that, even if you can't change ownership rules, to trying to encourage these pharmacists to be part of the, community centers and primary healthcare networks, that will improve adherence services for patients. And in making all of these changes, the patient mindset, where they often see they trust the doctor more because they see pharmacists as simply selling them a drug, I think it will take some time, but that also needs to be changed to have patients accepting of pharmacy services, which is now probably the case in Australia, but it wasn't the case when I started doing my PhD in 1998. So it's taken that much time for that shift in, trust in pharmacists. I would also recommend, because you asked about adherence particularly, so you do have universal health coverage, and it's really important. When I was looking at the list of asthma drugs in the national formulary, and of course I'm not Indonesian and I cannot read Bahasa, so I have to rely on my friends to tell me what's on the list. I find that we probably need more, whilst they may be more expensive, but more effective, anti-inflammatory medicines to be on the universal health coverage. Because once a patient can really derive benefit without too much side effect, that's a big starting point for adherence. So really making sure that your best combinations with your inhaled corticosteroids and long-acting beta agonists are actually on the universal health coverage. And there's a shift away from overusing salbutamol, which indeed for adults, the GINA guidelines and our own guidelines say no adult should be using salbutamol by itself. And we are even trying to change our emergency guidelines to shift to the budesonide formoterol combination. So I think that's a starting point to ensure that these medicines are covered through your universal health coverage, and there's a wide variety. And whilst it may be difficult, because I'm not sure how the UHC is funded, but those at the severe end of the spectrum, whether that's asthma or COPD or allergic rhinitis or eczema, as I was showing you that picture with the and it almost links to pharmacogenomics as well. We have different endotypes for asthma. So there are particular endotypes that respond really well to inhaled corticosteroids, but there may be some people who don't. They have a different, they're not really the Th2 type of inflammation. It still might be the T helper 1 type inflammation. So being able to test for those endotypes and targeting treatments, which goes back to Professor Sharif's talk, not directly pharmacogenomics, but individualizing medicines, is really important. Even though biologics are expensive, but they are miraculous to a point where the research in the respiratory world is now not about, how to measure asthma control. It's really how to define asthma remission in people who are using biologics. So that's something to think about regarding having the right medicines on the universal health coverage and having very good criteria for who's getting these medicines and being able to monitor patients regularly. Long answer for a very relevant question.
Yeah, yeah, it is. But thank you for the question, and thank you, Prof. Bandana Saini, for your response. And we have next question, Prof.
Yep.
Are we
You
ready
want to
for
read
you?
it out? Yep.
Yeah, okay. The question is from Miss Nanda. Okay, pardon me. The question is
Yep.
from Mrs. Nanda. The question is about how can pharmacy in Indonesia practically initiate community level respiratory or sleep screening and diagnosis service, and how can they ensure the integrity and accuracy of referral to specialists, thereby becoming trusted partner in addressing this critical underdiagnosis issue?
Thank you. Another very interesting question. I'm so stimulated by these questions. I think that what you need is to have a very big role of your professional organizations. Your Indonesian Pharmacist Association or whoever the right association is, where they develop standards of practice, and any pharmacist that's going to offer these services must actually complete that training, and that training has to be post, your registration training, so not B Pharm or PharmD. It has to be more specialized. They need to complete that training, show that they're competent, maintain their continuing professional development as a minimal. And I think by doing that and documenting that it is being done will inspire confidence in others. And I would say that even though I presented to you that we are doing sleep studies, whilst the pharmacist initiates the sleep study, and many of these pharmacists can understand sleep studies, but the diagnosis still must be done by a sleep physician. However, there are some less serious illnesses, as I said, conjunctivitis or allergic rhinitis, where pharmacists can potentially do an initial diagnosis. But I would really not recommend that we move into diagnosing. We really should be moving into better management of already diagnosed conditions as a start. And the underdiagnosis issue that you question, for COPD, for lung cancer, for apnea, for so many other conditions, what we do is simply we put together some very well-defined research questionnaires that are proven to be able to have good sensitivity or specificity in defining an issue. We use those so we understand that the patient is at risk. We send that referral to the doctor by saying, we have used X and Y and Z screening instruments that are validated in the research literature, and the patient appears to be at risk. We don't say we diagnose or you diagnose, we just say the patient appears to be at risk, and then it's in the medical domain to test further or to diagnose straight away. So I think what we can really do is not screening per se, but it's more like a opportunistic case detection and facilitating diagnosis through referral and triage. Happy to move to the next question.
Yes, this is the last question, Prof. Bandana. Coming for Mr. Afrizal. The question is, healthcare challenges in Indonesia vary significantly between urban areas and rural areas. Should effective respiratory pharmacy service be implemented using fundamentally different models or for the urban versus rural context? And what strategic lesson can be drawn from Australia experience with outreach or remote service to empower pharmacists in remote Indonesian region to deliver high-quality respiratory counseling?
Another very thought-provoking question, and I do agree, I certainly agree that even in Australia, the exposures in rural or farm regions are different to the urban regions. So urban regions, you have, diesel exhaust fumes and pollution and so on. In rural areas, you probably have more pollen, grass pollen, which is a big cause of thunderstorm asthma, etc. So essentially what we have done is that the Medicare system, the pharmaceutical benefit scheme, they are all the same across Australia. Australia also has a very big landmass that is underpopulated, so very remote areas as well. We've tried to build an awareness of what the specialized issues in these remote areas are. We do have different networks and communities of practice that are organized by our pharmaceutical society. So there's a rural and regional pharmacist network. They have their own conferences where they can discuss the issues. But the standards of care are actually applied nationally. So, for example, when we train patients, you might ask them to think about if someone's doing a sleep study, and the sleep specialist who is going to diagnose looking at the answers of that sleep study is only coming once in 2 weeks into your rural area, what is the process that you will set up to facilitate diagnosis? And one of the things we have really used is teleconsults and telehealth. That have worked both for the medical, particularly I would say for the medical fields in rural and regional areas. So my thought, as I said, I'm not the expert of everything, and I'm only sharing my thoughts based on my experience. My thought would be that the standards of practice or the service models you develop have to be uniform and standard across the country. But when you train people in regional areas, you should bring in regional experts and ensure that there are discussions about how you will implement that model in the regional or rural or very remote location. And for us in rural and remote regions, we also have to think about the sociocultural context where there may be more Indigenous Australians compared to urban areas, although that's not really the case anymore, but we certainly cater to particular populations. So there's a separate set of standards to service Indigenous Australians because their needs might be more and they might be different to that of the non-Indigenous Australians. I hope that those examples provide you with some food for thought on what to do next. But I would imagine all the students in the audience, you are the future of pharmacy in Indonesia, and hopefully, you can carry this baton forward.
Okay, thank you, Prof. Bandana Saini, for the valuable insight and for addressing the participant question. I believe our time is up for this question and answer session. Due to time constraints, we apologize for any question that could not be addressed. Ladies and gentlemen, from Mr. Sharif Mahmud and from Prof. Bandana Saini presentation, we have learned several key points. First, pharmacies are essential contributor to personalized, safe, and effective patient care, especially in complex fields like neurology. By strengthening our clinical roles, collaborating across profession, and using evidence-driven personalized approach, we can significantly improve patient outcome across the globe. Second, pharmacists, especially in community pharmacies, we have immense potential to transform from mere medicine dispense into key partner in the management of chronic respiratory disease such as asthma, COPD, and obstructive sleep apnea. The Australian experience proved that pharmacy interventions such as the Pharmacy Asthma Management Service are not only feasible but also highly effective into improving patient asthma control, correcting inhaler technique, and even conducting early screening for COPD. Ladies and gentlemen, thank you all for your attention and participation. I hope you have enjoyed this session and get some valuable insight and knowledge from our speakers. Please stay with us as we still have two more equally fascinating speakers who will share their expertise with us after the break. Okay, once again, thank you, Prof. Bandana Saini and Mr. Sharif Mahmud, for joining us today in this conference. Okay. At this point, I will hand the session back to our MC, who will guide us through the next part of the program. We look forward to welcoming you to our next session. Thank you very much.
Thank you, Mrs. Arina, for guiding us through a productive session today. Now, we will have 50-minute break. You may use this time to rest, refresh yourself, or prepare for the next session. We will be back at 12 p.m. Western Indonesian time. We would also like to remind all attendants to complete the attendance form, which has been provided by the committee through the link posted in the chat room. Thank you very much.
Di usia yang masih sangatlah muda, Unjaya terus bertransformasi, mewujudkan cita-cita menjadi universitas yang unggul dan berwawasan global. Sebagai universitas milik Yayasan Kartika Eka Paksi, di bawah binaan langsung TNI Angkatan Darat, Unjaya menjawab tantangan pendidikan tinggi di era disrupsi dengan bertransformasi melalui penguatan wawasan global dan ketahanan nasional dalam visi dan misinya, serta berpegang teguh pada nilai-nilai kejuangan Jenderal Ahmad Yani. Berbagai prestasi di bidang akademik, kreativitas, inovasi, dan kemahasiswaan banyak dicapai para Ahmad Yani muda. Selain itu, pengembangan keilmuan melalui metode student-centered learning dan project-based learning, magang, program kewirausahaan mahasiswa, festival karya mahasiswa, dan Ahmad Yani Mudapreneur merupakan salah satu bentuk transformasi ekosistem Unjaya agar mampu berdampak lebih luas bagi masyarakat. Sebagai lanjutan dari upaya penguatan internal dan transformasi digital, Unjaya menata kembali hubungan antar unit kerja untuk meningkatkan layanan yang efektif, efisien, dan transparan sebagai tanggung jawab perguruan tinggi sebagai salah satu lokomotif perubahan. Proses transformasi tersebut ditandai dengan aktivasi Pusat Akses Terintegrasi untuk Optimalisasi Tata Kelola atau Patriot. Patriot merupakan sistem informasi terintegrasi yang menyatukan semua layanan di Unjaya dalam satu genggaman. Transformasi tersebut menjadi salah satu bentuk komitmen Unjaya untuk membentuk masa depan pendidikan yang menjangkau lebih banyak, melayani lebih dalam, dan berdampak lebih luas bagi generasi penerus bangsa yang
Nasionalis, patriotik, heroik.
Yogyakarta adalah kota yang penuh dengan sejarah, budaya, dan semangat kebangsaan. Kota di mana setiap jalan berasa dijahit erat dengan kisah-kisah kepahlawanan dan pengabdian kepada negara. Dan di tengah-tengah gemerlapnya Yogyakarta, terdapat sebuah institusi pendidikan yang mengemban misi besar. Selamat datang di Fakultas Kesehatan Universitas Jenderal Ahmad Yani, sebuah tempat di mana semangat kebangsaan dipelihara dan para pemimpin masa depan kita dibentuk. Di sini, para pendidik bekerja tanpa lelah untuk memastikan bahwa pendidikan yang diberikan sesuai dengan standar pendidikan nasional. Mereka adalah pemimpin yang bijaksana yang membimbing mahasiswa dalam perjalanan mereka mencapai mimpi dan potensi tertinggi mereka. Fakultas Kesehatan Universitas Jenderal Ahmad Yani memiliki 8 program studi. Prodi Keperawatan S1 merupakan program pendidikan tahap akademik yang bertujuan untuk mempersiapkan mahasiswa menjadi calon perawat profesional melalui pendidikan berkelanjutan pada tahap profesi. Pada tahap akademik ini, mahasiswa dibekali dengan pengetahuan terkait teori dan dasar-dasar ilmu keperawatan melalui pembelajaran di kelas, laboratorium, dan juga praktik. Prodi Profesi Nurse merupakan program lanjutan dari pendidikan sarjana keperawatan untuk mempersiapkan lulusan menjadi perawat profesional. Pengalaman belajar dilaksanakan di rumah sakit, puskesmas, klinik maupun masyarakat selama 1 tahun. Prodi Kebidanan D3, program pendidikan vokasi yang mempersiapkan mahasiswa untuk menjadi bidan yang terampil dalam memberikan pelayanan kebidanan kepada remaja, ibu hamil, ibu melahirkan, ibu pasca melahirkan, bayi baru lahir, neonatus, bayi, balita, dan ibu klimakterium, serta terampil dalam memberikan pelayanan komplementer kepada ibu dan anak. Prodi Kebidanan S1 merupakan program studi yang mempersiapkan mahasiswa menjadi calon bidan profesional yang secara akademik dipersiapkan untuk menempuh jenjang pendidikan profesi, sehingga dapat memberikan pelayanan kebidanan sesuai kompetensi bidan. Prodi Profesi Bidan. Prodi Profesi Bidan merupakan program lanjutan dari pendidikan sarjana kebidanan untuk mempersiapkan lulusan menjadi bidan profesional. Pada tahap ini, mahasiswa dibekali dengan pembelajaran praktik di berbagai wahana praktik, meliputi rumah sakit, puskesmas, klinik pratama, dan praktik mandiri bidan yang ditempuh selama 1 tahun. Prodi Rekam Medis. Program studi ini membekali mahasiswa dengan pengetahuan dan keterampilan untuk mengelola informasi medis dan kesehatan berbasis elektronik, termasuk pengumpulan, penyimpanan, analisis, dan penggunaan data kesehatan yang penting untuk pengambilan keputusan klinis dan administratif. Prodi Teknologi Bank Darah. Program studi ini fokus pada pengembangan teknologi terkait pengelolaan penyediaan dan penggunaan darah untuk kepentingan transfusi dalam konteks pelayanan kesehatan, termasuk proses pengumpulan, pengamanan, penyimpanan, pengujian mutu dan distribusi darah, serta produk darah lainnya. Prodi Farmasi S1, program studi farmasi ditempuh selama 4 tahun untuk mempersiapkan mahasiswa menuju jenjang profesi sebagai apoteker profesional. Pada program studi ini, mahasiswa akan mempelajari tentang obat-obatan, dosis, efek samping, interaksi obat, dan cara memberikan informasi serta layanan farmasi kepada pasien guna mewujudkan kesehatan yang optimal. Di sini, kami bangga menyediakan sarana dan prasarana bagi mahasiswa untuk meraih potensi terbaik mereka. Ruang kelas. Ruang kelas kami didesain dengan nyaman untuk menciptakan lingkungan belajar yang inspiratif, dilengkapi dengan teknologi terkini dan fasilitas yang memadai. Setiap kelas mencerminkan standar kualitas tinggi kami dalam pendidikan. Ruang tutorial. Tempat di mana diskusi dan interaksi antara dosen dan mahasiswa menjadi inti dari pembelajaran. Ruang tutorial kami dirancang untuk mendukung kolaborasi dan pemahaman mendalam tentang materi pelajaran. Lab terpadu. Laboratorium terpadu menyediakan fasilitas lengkap untuk pembelajaran praktikum mahasiswa semua program studi. Dengan peralatan modern dan ruang yang luas, mahasiswa dapat mengeksplorasi konsep-konsep ilmiah secara praktis. OSCE Center. Di sini, mahasiswa dapat mengasah keterampilan klinis mereka melalui simulasi yang realistis. OSCE Center dilengkapi dengan fasilitas terkini untuk mempersiapkan mahasiswa menjadi tenaga kesehatan profesional. Lab komputer. Fasilitas laboratorium komputer menyediakan akses ke perangkat keras dan perangkat lunak terbaru. Dengan ruang yang nyaman dan fasilitas yang lengkap, mahasiswa dapat mengembangkan keterampilan teknologi yang diperlukan di era digital ini. Lab CBT, Computer Based Test. Lab ini dirancang khusus untuk ujian berbasis komputer, menguji pemahaman mahasiswa dalam format yang interaktif dan adaptif. Ruang webinar. Kami juga menyediakan ruang webinar yang dilengkapi dengan teknologi mutakhir. Fasilitas ini juga bisa untuk menyelenggarakan seminar, workshop, dan presentasi online yang interaktif dan informatif. Asrama mahasiswa. Untuk kenyamanan dan kemudahan akses, kami menyediakan asrama mahasiswa yang modern dan aman. Ini adalah tempat yang nyaman bagi mahasiswa untuk tinggal dan berkembang dalam suasana akademis yang mendukung. Perpustakaan. Koleksi perpustakaan kami mencakup berbagai sumber belajar, mulai dari buku dan jurnal, baik cetak maupun elektronik. Ini adalah tempat yang ideal bagi mahasiswa untuk mengeksplorasi pengetahuan dan melakukan riset. Student Corner. Tempat bertemu, berdiskusi, dan berkolaborasi antar mahasiswa. Student Corner adalah pusat kegiatan sosial dan akademis di kampus kami. Lapangan basket. Untuk menjaga keseimbangan antara belajar dan kesehatan jasmani, kami memiliki lapangan basket. Ini adalah tempat yang sempurna bagi mahasiswa untuk melepaskan energi dan menjaga kebugaran fisik. Apotek. Kami juga menyediakan apotek di kampus, memastikan kebutuhan kesehatan mahasiswa dan masyarakat umum terpenuhi dengan baik. Fakultas Kesehatan Universitas Jenderal Ahmad Yani siap membentuk para Ahmad Yani muda yang nasionalis, patriotik, heroik. Bersama-sama kita akan melangkah maju menuju masa depan yang lebih baik untuk kemajuan Indonesia. Mari kita bersama-sama menjadi bagian dari perubahan di Universitas Jenderal Ahmad Yani.
Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta siap mendidik dan mempersiapkan para Ahmad Yani muda bidang kesehatan sebagai generasi penerus kejayaan bangsa Indonesia.
Unjaya, nasionalis, patriotik, heroik.
Yogyakarta, kota istimewa yang dikenal sebagai denyut nadi pendidikan Indonesia. Disinilah ribuan mimpi dan cita-cita masa depan dirajut di tengah atmosfer akademisi yang kental ini. Universitas Jenderal Ahmad Yani hadir sebagai kawah candra di muka, mendedikasikan diri untuk melahirkan generasi kesehatan yang unggul dan berjiwa kebangsaan.
Selamat datang di program studi farmasi S1 Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta, Unjaya. Prodi Farmasi Unjaya memulai operasional pembelajaran pada tahun 2017 dan telah memperoleh akreditasi B dari LAMPTKES pada tahun 2021. Prodi Farmasi Unjaya berkomitmen untuk terus meningkatkan mutu menuju akreditasi unggul. Visi Prodi Farmasi adalah menjadi program studi yang unggul, berwawasan global, memiliki penciri promosi kesehatan di bidang kefarmasian yang berbasis bukti, dengan semangat kejuangan Jenderal Ahmad Yani. Prodi Farmasi Unjaya memadukan pendidikan kefarmasian yang berwawasan global dengan promosi kesehatan berbasis bukti agar lulusan tidak hanya menguasai obat dan produk kesehatan, tetapi juga mampu berperan aktif dalam edukasi, advokasi, dan pemberdayaan masyarakat.
Perkuliahan dirancang selama 8 semester dengan total 146 SKS, mengacu pada kurikulum KKNI, APTFI, serta standar profesi apoteker. Proses pembelajaran menerapkan pendekatan student-centered learning untuk menumbuhkan kemandirian dan berpikir kritis. Prodi Farmasi Unjaya didukung fasilitas pembelajaran lengkap, modern, dan terintegrasi sistem informasi. Mulai dari ruang kelas representatif, perpustakaan dengan koleksi pustaka yang memadai, ruang CBT, evaluasi dilakukan secara objektif melalui komputer based test CBT. Ruang OSCE, Objective Structure Clinical Examination OSCE, guna menjamin kompetensi yang terukur. Kegiatan akademik diampu oleh dosen berpengalaman dengan kualifikasi profesor, doktor, dan magister dari 5 kelompok keilmuan. Dosen kelompok keilmuan teknologi farmasi, dosen keilmuan teknologi biologi farmasi, dosen kelompok keilmuan kimia farmasi, dosen kelompok keilmuan farmasi klinik dan komunitas, dosen kelompok keilmuan manajemen farmasi. Serta didukung oleh staf kependidikan prodi yang terdiri dari laboran dan admin. Juga memiliki laboratorium terstandar yang terdiri dari Laboratorium Teknologi Farmasi, Laboratorium Kimia Farmasi, Laboratorium Biofarmakologi, Laboratorium Bahan Alam dan Mikrobiologi, Laboratorium Farmasi Klinik dan Komunitas, serta Laboratorium Instrumen dan Penelitian. Mahasiswa Farmasi Unjaya aktif memperoleh pencapaian di berbagai ajang kompetensi bergengsi tingkat nasional, khususnya dalam bidang kefarmasian, sains, dan riset ilmiah. Kami mempersiapkan sarjana farmasi berwawasan global, adaptif, serta berkarakter profesional dan humanis. Selain keunggulan akademik, kami juga fokus pada peningkatan leadership dan soft skill mahasiswa melalui Himpunan Mahasiswa Farmasi atau Himafar. Berbagai kegiatan prestatif rutin dilaksanakan, mulai dari keikutsertaan dalam International Society Pharmaceutical Engineering (ISPE), pelatihan kepemimpinan manajemen mahasiswa farmasi (LKMMF), musyawarah besar, Pharmafest, hingga berbagai workshop pengembangan diri. Ekosistem organisasi yang kuat terbukti melahirkan budaya prestasi yang gemilang. Profil lulusan kami mencerminkan integrasi ilmu dan etika sebagai caregiver, communicator, decision maker, manager, leader, researcher, teacher, entrepreneur, long life learner, serta health promoter. Lulusan sarjana farmasi memiliki peluang karir luas dalam pelayanan kefarmasian di rumah sakit dan apotek, industri farmasi pada bidang produksi, QC dan R&D, regulasi pemerintahan di BPOM atau Kemenkes, wirausaha produk herbal dan startup digital, hingga menjadi akademisi dan peneliti. Upaya kami adalah terus meningkatkan kualitas dan menghasilkan lulusan berkarakter. Bergabunglah bersama kami, program studi farmasi, Fakultas Kesehatan Universitas Jenderal Ahmad Yani, Yogyakarta.
Farmasi Unjaya, nasionalis, patriotik, heroik.
Selamat datang di PT Kairos Jaya Sejahtera, sebuah perusahaan PMDN yang didirikan di Kabupaten Sleman, Daerah Istimewa Yogyakarta pada tahun 2014. Kami hadir untuk memberikan pelayanan distribusi khususnya dalam bidang laboratorium. Visi kami adalah untuk menjadi distributor berskala nasional yang menjadi pilihan utama bagi pelanggan dan mitra usaha. Dengan berlandaskan pada nilai profesionalisme dan humanisme, mendorong kami untuk melakukan kegiatan distribusi yang terstandar, sehingga mampu memberikan layanan dan produk yang berkualitas. PT Kairos Jaya Sejahtera hadir untuk menjadi mitra dalam setiap kegiatan laboratorium Anda. Kami memiliki rentang produk yang luas untuk melayani kebutuhan laboratorium, seperti produk untuk penelitian genom dengan menggunakan PCR, penelitian protein dengan metode Western blot, immunohistochemistry, ELISA, dan bioassay lainnya. Penelitian mikrobiologi, sel kultur, kimia analisa, dan penelitian terkait life science lainnya. Pelayanan informasi yang detail terhadap produk dimulai dari tahap pre-order hingga after sale service menjadi kunci keberhasilan kegiatan laboratorium pelanggan kami. Standar operasional prosedur dalam kegiatan distribusi diterapkan sedemikian rupa sesuai dengan kebutuhan setiap produk. Proses penerimaan, penyimpanan, dan pengiriman barang diawasi dengan ketat sesuai dengan standar mutu yang ditetapkan. Didukung oleh sumber daya manusia yang terlatih dan sarana-prasarana yang terkendali, menciptakan sinergi dalam menjaga mutu produk selama distribusi. Sistem informasi perusahaan yang diintegrasikan pada semua divisi meningkatkan kecepatan dan akurasi data dalam kegiatan distribusi, sehingga proses distribusi dapat berjalan dengan prima. Kami, PT Kairos Jaya Sejahtera, memberikan layanan purna jual untuk memastikan terciptanya kepuasan pelanggan. Kami melayani diskusi pada tahap pemilihan spesifikasi demi mendapatkan produk yang sesuai dengan kebutuhan pelanggan. Pendampingan kegiatan laboratorium dalam rangka menciptakan keberhasilan penggunaan produk adalah salah satu fokus kami dalam melayani pelanggan. Selain itu, dengan senang hati, kami akan berkolaborasi dalam kegiatan pengembangan laboratorium. Berkat anugerah Tuhan yang Maha Kuasa, serta segala usaha dan komitmen dari seluruh tim PT Kairos Jaya Sejahtera, sampai saat ini PT Kairos Jaya Sejahtera dapat melayani distribusi ke sebagian besar wilayah di Indonesia. Dengan semangat, doa, dan upaya dalam menjamin mutu distribusi, PT Kairos Jaya Sejahtera akan melayani dengan lebih baik dengan harapan akan terciptanya kesuksesan dan kemajuan dunia usaha, ilmu pengetahuan, kesehatan, dan bangsa Indonesia.
Halo, mahasiswa farmasi Indonesia, sudah pakai aplikasi obat apps belum? Aplikasi belajar farmasi nomor 1 di Indonesia. Buat belajar farmasi lebih asik dan seru. Yuk cobain 5 fitur super keren yang ada di obat apps. Fitur pertama, jenjang pendidikan dan persiapan ujian. Di obat apps, semua jenjang pendidikan farmasi mulai dari SMK, D3, S1 Farmasi, dan profesi apoteker punya kurikulum terstandar dan materi tersendiri. Bahkan, memfasilitasi kamu untuk persiapan ujian UKAI, UKTTK, hingga masuk apoteker, dijamin deh lulus. Fitur kedua, journey belajar farmasi lengkap. Belajar farmasi lebih menarik dan lengkap karena ribuan video materi yang tersedia dilengkapi dengan ribuan evaluasi kuis dan latihan soal, hingga pembahasan soal. Juga tersedia ribuan soal ujian farmasi dari semua jenjang pendidikan yang telah dibedah oleh super mentor dengan lengkap, beserta tips dan trik pengerjaannya. Yakin deh, kamu bakalan paham, karena semua kontennya telah disupervisi oleh ahlinya. Fitur ketiga, live teaching. Belajar farmasi kapanpun dan dimanapun, dipandu oleh super mentor, dosen, hingga praktisi melalui live teaching. Gak hanya mengasah hard skill, tersedia puluhan tema soft skill seperti Pharmapreneur, communication, hingga career. Kamu semakin mantap bersaing di era global. Fitur keempat, try out dan kuis mingguan. Kerjakan ribuan kuis materi kefarmasian dan ratusan tryout ujian dari berbagai jenjang pendidikan farmasi. Menangkan hadiah jutaan rupiah setiap minggunya. Fitur kelima, buku digital. Zaman sekarang, semua serba digital. Yuk hemat dan efisien biaya dengan menggunakan buku digital. Tersedia ratusan buku digital farmasi yang bisa kamu jadikan referensi dan belajar. Lebih mudah, terjangkau, dan lengkap pastinya. Ayo download dan install sekarang juga aplikasi Obat Apps di gadget kamu dan jadi bagian dari revolusi pendidikan farmasi Indonesia. Obat Apps tersedia di Play Store dan App Store.
Di usia yang masih sangatlah muda, Unjaya terus bertransformasi, mewujudkan cita-cita menjadi universitas yang unggul dan berwawasan global. Sebagai universitas milik Yayasan Kartika Eka Paksi, di bawah binaan langsung TNI Angkatan Darat, Unjaya menjawab tantangan pendidikan tinggi di era disrupsi dengan bertransformasi melalui penguatan wawasan global dan ketahanan nasional dalam visi dan misinya, serta berpegang teguh pada nilai-nilai kejuangan Jenderal Ahmad Yani. Berbagai prestasi di bidang akademik, kreativitas, inovasi, dan kemahasiswaan banyak dicapai para Ahmad Yani muda. Selain itu, pengembangan keilmuan melalui metode student-centered learning dan project-based learning, magang, program kewirausahaan mahasiswa, festival karya mahasiswa, dan Ahmad Yani Mudapreneur merupakan salah satu bentuk transformasi ekosistem Unjaya agar mampu berdampak lebih luas bagi masyarakat. Sebagai lanjutan dari upaya penguatan internal dan transformasi digital, Unjaya menata kembali hubungan antar unit kerja untuk meningkatkan layanan yang efektif, efisien, dan transparan sebagai tanggung jawab perguruan tinggi sebagai salah satu lokomotif perubahan. Proses transformasi tersebut ditandai dengan aktivasi pusat akses terintegrasi untuk optimalisasi tata kelola atau Patriot. Patriot merupakan sistem informasi terintegrasi yang menyatukan semua layanan di Unjaya dalam satu genggaman. Transformasi tersebut menjadi salah satu bentuk komitmen Unjaya untuk membentuk masa depan pendidikan yang menjangkau lebih banyak, melayani lebih dalam, dan berdampak lebih luas bagi generasi penerus bangsa yang nasionalis, patriotik, heroik.
Yogyakarta adalah kota yang penuh dengan sejarah, budaya, dan semangat kebangsaan. Kota di mana setiap jalan berasa dijahit erat dengan kisah-kisah kepahlawanan dan pengabdian kepada negara. Dan di tengah-tengah gemerlapnya Yogyakarta, terdapat sebuah institusi pendidikan yang mengemban misi besar. Selamat datang di Fakultas Kesehatan Universitas Jenderal Ahmad Yani, sebuah tempat di mana semangat kebangsaan dipelihara dan para pemimpin masa depan kita dibentuk. Di sini, para pendidik bekerja tanpa lelah untuk memastikan bahwa pendidikan yang diberikan sesuai dengan standar pendidikan nasional. Mereka adalah pemimpin yang bijaksana yang membimbing mahasiswa dalam perjalanan mereka mencapai mimpi dan potensi tertinggi mereka. Fakultas Kesehatan Universitas Jenderal Ahmad Yani memiliki 8 program studi. Prodi Keperawatan S1 merupakan program pendidikan tahap akademik yang bertujuan untuk mempersiapkan mahasiswa menjadi calon perawat profesional melalui pendidikan berkelanjutan pada tahap profesi. Pada tahap akademik ini, mahasiswa dibekali dengan pengetahuan terkait teori dan dasar-dasar ilmu keperawatan melalui pembelajaran di kelas, laboratorium, dan juga praktik. Prodi Profesi Nurse merupakan program lanjutan dari pendidikan sarjana keperawatan untuk mempersiapkan lulusan menjadi perawat profesional. Pengalaman belajar dilaksanakan di rumah sakit, puskesmas, klinik maupun masyarakat selama 1 tahun. Prodi Kebidanan D3, program pendidikan vokasi yang mempersiapkan mahasiswa untuk menjadi bidan yang terampil dalam memberikan pelayanan kebidanan kepada remaja, ibu hamil, ibu melahirkan, ibu pasca melahirkan, bayi baru lahir, neonatus, bayi, balita, dan ibu klimakterium, serta terampil dalam memberikan pelayanan komplementer kepada ibu dan anak. Prodi Kebidanan S1 merupakan program studi yang mempersiapkan mahasiswa menjadi calon bidan profesional yang secara akademik dipersiapkan untuk menempuh jenjang pendidikan profesi, sehingga dapat memberikan pelayanan kebidanan sesuai kompetensi bidan. Prodi Profesi Bidan. Prodi Profesi Bidan merupakan program lanjutan dari pendidikan sarjana kebidanan untuk mempersiapkan lulusan menjadi bidan profesional. Pada tahap ini, mahasiswa dibekali dengan pembelajaran praktik di berbagai wahana praktik, meliputi rumah sakit, puskesmas, klinik pratama, dan praktik mandiri bidan yang ditempuh selama 1 tahun. Prodi Rekam Medis. Program studi ini membekali mahasiswa dengan pengetahuan dan keterampilan untuk mengelola informasi medis dan kesehatan berbasis elektronik, termasuk pengumpulan, penyimpanan, analisis, dan penggunaan data kesehatan yang penting untuk pengambilan keputusan klinis dan administratif. Prodi Teknologi Bank Darah. Program studi ini fokus pada pengembangan teknologi terkait pengelolaan penyediaan dan penggunaan darah untuk kepentingan transfusi dalam konteks pelayanan kesehatan, termasuk proses pengumpulan, pengamanan, penyimpanan, pengujian mutu dan distribusi darah, serta produk darah lainnya. Prodi Farmasi S1. Program studi farmasi ditempuh selama 4 tahun untuk mempersiapkan mahasiswa menuju jenjang profesi sebagai apoteker profesional. Pada program studi ini, mahasiswa akan mempelajari tentang obat-obatan, dosis, efek samping, interaksi obat, dan cara memberikan informasi serta layanan farmasi kepada pasien guna mewujudkan kesehatan yang optimal. Di sini, kami bangga menyediakan sarana dan prasarana bagi mahasiswa untuk meraih potensi terbaik mereka. Ruang kelas. Ruang kelas kami didesain dengan nyaman untuk menciptakan lingkungan belajar yang inspiratif, dilengkapi dengan teknologi terkini dan fasilitas yang memadai. Setiap kelas mencerminkan standar kualitas tinggi kami dalam pendidikan. Ruang tutorial, tempat di mana diskusi dan interaksi antara dosen dan mahasiswa menjadi inti dari pembelajaran. Ruang tutorial kami dirancang untuk mendukung kolaborasi dan pemahaman mendalam tentang materi pelajaran. Lab terpadu, laboratorium terpadu menyediakan fasilitas lengkap untuk pembelajaran praktikum mahasiswa semua program studi. Dengan peralatan modern dan ruang yang luas, mahasiswa dapat mengeksplorasi konsep-konsep ilmiah secara praktis. OSCE Center. Di sini, mahasiswa dapat mengasah keterampilan klinis mereka melalui simulasi yang realistis. OSCE Center dilengkapi dengan fasilitas terkini untuk mempersiapkan mahasiswa menjadi tenaga kesehatan profesional. Lab komputer. Fasilitas laboratorium komputer menyediakan akses ke perangkat keras dan perangkat lunak terbaru. Dengan ruang yang nyaman dan fasilitas yang lengkap, mahasiswa dapat mengembangkan keterampilan teknologi yang diperlukan di era digital ini. Lab CBT, Computer Based Test. Lab ini dirancang khusus untuk ujian berbasis komputer, menguji pemahaman mahasiswa dalam format yang interaktif dan adaptif. Ruang webinar. Kami juga menyediakan ruang webinar yang dilengkapi dengan teknologi mutakhir. Fasilitas ini juga bisa untuk menyelenggarakan seminar, workshop, dan presentasi online yang interaktif dan informatif. Asrama mahasiswa. Untuk kenyamanan dan kemudahan akses, kami menyediakan asrama mahasiswa yang modern dan aman. Ini adalah tempat yang nyaman bagi mahasiswa untuk tinggal dan berkembang dalam suasana akademis yang mendukung. Perpustakaan. Koleksi perpustakaan kami mencakup berbagai sumber belajar, mulai dari buku dan jurnal, baik cetak maupun elektronik. Ini adalah tempat yang ideal bagi mahasiswa untuk mengeksplorasi pengetahuan dan melakukan riset. Student Corner. Tempat bertemu, berdiskusi, dan berkolaborasi antar mahasiswa. Student Corner adalah pusat kegiatan sosial dan akademis di kampus kami. Lapangan basket. Untuk menjaga keseimbangan antara belajar dan kesehatan jasmani, kami memiliki lapangan basket. Ini adalah tempat yang sempurna bagi mahasiswa untuk melepaskan energi dan menjaga kebugaran fisik. Apotek. Kami juga menyediakan apotek di kampus, memastikan kebutuhan kesehatan mahasiswa dan masyarakat umum terpenuhi dengan baik. Fakultas Kesehatan Universitas Jenderal Ahmad Yani siap membentuk para Ahmad Yani muda yang nasionalis, patriotik, heroik. Bersama-sama kita akan melangkah maju menuju masa depan yang lebih baik untuk kemajuan Indonesia. Mari kita bersama-sama menjadi bagian dari perubahan di Universitas Jenderal Ahmad Yani.
Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta siap mendidik dan mempersiapkan para Ahmad Yani muda bidang kesehatan sebagai generasi penerus kejayaan bangsa Indonesia.
Unjaya, nasionalis, patriotik, heroik.
Yogyakarta, kota istimewa yang dikenal sebagai denyut nadi pendidikan Indonesia. Disinilah ribuan mimpi dan cita-cita masa depan dirajut di tengah atmosfer akademisi yang kental ini. Universitas Jenderal Ahmad Yani hadir sebagai kawah candra di muka, mendedikasikan diri untuk melahirkan generasi kesehatan yang unggul dan berjiwa kebangsaan.
Selamat datang di program studi farmasi S1 Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta, Unjaya. Prodi Farmasi Unjaya memulai operasional pembelajaran pada tahun 2017 dan telah memperoleh akreditasi B dari LAMPTKES pada tahun 2021. Prodi Farmasi Unjaya berkomitmen untuk terus meningkatkan mutu menuju akreditasi unggul. Visi Prodi Farmasi adalah menjadi program studi yang unggul, berwawasan global, memiliki penciri promosi kesehatan di bidang kefarmasian yang berbasis bukti, dengan semangat kejuangan Jenderal Ahmad Yani. Prodi Farmasi Unjaya memadukan pendidikan kefarmasian yang berwawasan global dengan promosi kesehatan berbasis bukti, agar lulusan tidak hanya menguasai obat dan produk kesehatan, tetapi juga mampu berperan aktif dalam edukasi, advokasi, dan pemberdayaan masyarakat.
Perkuliahan dirancang selama 8 semester dengan total 146 SKS, mengacu pada kurikulum KKNI, APTFI, serta standar profesi apoteker. Pembelajaran menerapkan pendekatan student-centered learning untuk menumbuhkan kemandirian dan berpikir kritis. Prodi Farmasi Unjaya didukung fasilitas pembelajaran lengkap, modern, dan terintegrasi sistem informasi. Mulai dari ruang kelas representatif, perpustakaan dengan koleksi pustaka yang memadai, ruang CBT, evaluasi dilakukan secara objektif melalui komputer based test CBT. Ruang OSCE, Objective Structure Clinical Examination OSCE, guna menjamin kompetensi yang terukur. Kegiatan akademik diampu oleh dosen berpengalaman dengan kualifikasi profesor, doktor, dan magister dari 5 kelompok keilmuan. Dosen kelompok keilmuan teknologi farmasi, dosen keilmuan teknologi biologi farmasi, dosen kelompok keilmuan kimia farmasi, dosen kelompok keilmuan farmasi klinik dan komunitas, dosen kelompok keilmuan manajemen farmasi. Serta didukung oleh staf kependidikan prodi yang terdiri dari laboran dan admin. Juga memiliki laboratorium terstandar yang terdiri dari Laboratorium Teknologi Farmasi, Laboratorium Kimia Farmasi, Laboratorium Biofarmakologi, Laboratorium Bahan Alam dan Mikrobiologi, Laboratorium Farmasi Klinik dan Komunitas, serta Laboratorium Instrumen dan Penelitian. Mahasiswa Farmasi Unjaya aktif memperoleh pencapaian di berbagai ajang kompetensi bergengsi tingkat nasional, khususnya dalam bidang kefarmasian, sains, dan riset ilmiah. Kami mempersiapkan sarjana farmasi berwawasan global, adaptif, serta berkarakter profesional dan humanis. Selain keunggulan akademik, kami juga fokus pada peningkatan leadership dan soft skill mahasiswa melalui Himpunan Mahasiswa Farmasi atau Himafar. Berbagai kegiatan prestatif rutin dilaksanakan, mulai dari keikutsertaan dalam International Society Pharmaceutical Engineering (ISPE), pelatihan kepemimpinan manajemen mahasiswa farmasi (LKMMF), musyawarah besar, Pharmafest, hingga berbagai workshop pengembangan diri. Ekosistem organisasi yang kuat terbukti melahirkan budaya prestasi yang gemilang. Profil lulusan kami mencerminkan integrasi ilmu dan etika sebagai caregiver, communicator, decision maker, manager, leader, researcher, teacher, entrepreneur, long life learner, serta health promoter. Lulusan sarjana farmasi memiliki peluang karir luas dalam pelayanan kefarmasian di rumah sakit dan apotek, industri farmasi pada bidang produksi, QC dan R&D, regulasi pemerintahan di BPOM atau Kemenkes, wirausaha produk herbal dan startup digital, hingga menjadi akademisi dan peneliti. Upaya kami adalah terus meningkatkan kualitas dan menghasilkan lulusan berkarakter. Bergabunglah bersama kami, program studi farmasi, Fakultas Kesehatan Universitas Jenderal Ahmad Yani, Yogyakarta.
Farmasi Unjaya, nasionalis, patriotik, heroik.
and gentlemen, welcome back to the second Unjaya International Conference on Pharmacy and Pharmaceutical Science with our grand theme, Strengthening the Role of Pharmacists in Global Health Issue. We will continue with our next session, which will be led by our moderator, Mr. Aska Muhammad. Mr. Aska Muhammad is a lecturer in the pharmacy department at Universitas Jenderal Ahmad Yani Yogyakarta. He teaches, writes, and conducts research in the field of pharmaceutical science. Mr. Aska Muhammad, the floor is yours.
Good morning, good afternoon, and good evening, everyone, wherever you are from. Welcome back to the second Unjaya International Conference on Pharmacy and Pharmaceutical Science, Unicopps 2025. This year's conference carries an important theme, strengthening the role of pharmacists in global health issue. Through this conference, we aim to strengthen collaboration, broaden scientific perspective, and encourage innovation in addressing today's global health challenges. My name is Aska Muhammad Rusdan, and it is truly an honor to serve as your moderator for today's scientific session. Now, in this second session, we have two outstanding speakers who will share their insight on strengthening the role of pharmacists in addressing global health challenges. We are very fortunate to have them with us, and I'm excited for the knowledge and inspiration they will bring today. And if you have a question you want to ask, feel free to write it down in the comment section. Now, let us begin our second session. Our first speaker is Professor Yoshihiro Hayakawa, BCS, MS, PhD. Ladies and gentlemen, allow me to briefly highlight Professor Hayakawa's academic journey and contribution. As you can see on the screen right now, Professor Hayakawa is a faculty member in Institute of Natural Medicine, University of Toyama, Japan. He holds a bachelor, master, and doctoral degree in pharmaceutical science from Toyama Medical Pharmaceutical University, and he has since built an impressive career in immunology and cancer biology research. With H index of 60 and thousands of citation in his name, his research consistency has earned him a significant influence in international scientific community. He continued to publish in top-tier journals such as Cancer Science, International Journal of Molecular Science and Bioorganic and Medical Chemistry. Throughout his careers, Professor Hayakawa has received multiple prestigious awards, with the most recently he received the Academic Contribution Award from the Japan Society of Medical and Pharmaceutical Science for Traditional Medicine in 2023. Now, his research and leadership, international collaboration, and contribution to medicinal science continue to inspire researchers around the world. Now, ladies and gentlemen, it is with my great pleasure to welcome our speakers for this session, Professor Yoshihiro Hayakawa. Hello, Professor Hayakawa. Welcome to Unicopps 2025.
Hi, can you hear me?
Your volume is a little bit low from us.
You hear me?
Yeah,
well?
It's much better.
Okay. Thanks for the invitation. As I got the introduced right now, this is Yoshihiro Hayakawa. I'm speaking from Toyama City, Japan, where we have these beautiful mountains. If you ever travel to Japan, but probably not to Toyama, So yeah, I really like to thank to the invitation today. So let me, because the time is limited, so I like to start my presentation right now. Talking about the global health issue, I'm going to talk about the cancer disease. And more specifically, I'm talking about how we can manipulate our cancer cell response against our host immune system, because cancer immunotherapy has been now emerging new therapy target for the cancer treatment. And in my lab is mainly working on the topic of cancer immunology. So my title here is Bridging Cancer Immunology and Pharmacy Practice from Mechanism to Medicine. Before talking about any specific data, it's very important to understand the concept of cancer immune surveillance and immunoediting process. Because as many of you may aware, the cancer cells are generally speaking, they becoming from the normal tissue, normal cells got transformed with various reasons, mainly like the gene mutation, bearing the gene mutations. And those transformed cells are not actually, the healthy cells in terms of our, the body. So our host immune system needs to, eliminate those non-self or something, harmful to your body. So no exception, the cancer cells also can be detected or identified by our immune system, and potentially could be rejected. And if it's all successful of this elimination step of cancer cells or transformed cells, we probably never get the cancer disease. However, reality is different. I mean, in Japan, nearly half of us will succumb to cancer disease, and probably the same situation is true for the Indonesia as well. So, but we are not all like immunodeficient, the host. So we are mostly healthy in terms of the immune response, like immunocompetent host. So what's happened during those tumor development is from a lot of evidences in the past 20, 30 years of research. We now knew that those cancer cells has proceed into the two different steps. One is equilibrium phase, and lastly the escape phase. And then where the cancer cells go through all those immunological pressure, but they acquire some new ability to escape from those immunological, the detection. So that's the very important concept, that most of the cancer cells, which clinically relevant cancer cells, somehow they acquire the certain mechanism to escape the immunological pressure. So saying that, the understanding of this escape mechanism is really important to identify the new target of the cancer therapy by manipulating our immune responses. And one of the highlighting of this escape mechanism is the molecule called immunocheckpoint molecules, such as PD-1, program-DES1, or CTLA-4. And the antibodies against those PD-1 or their ligand, or CTLA-4 or its ligand, has been developed as the immunocheckpoint inhibitor and used in the clinical situation, and has been working extremely well to treating multiple type of cancers. So that's why I'm stressing again here, the understanding how cancer cells are escaping from those immunological detection or immunological pressure is really important. That's something I will talk you in the last 20 minutes or so. So again, it's been known that these escape steps can be achieved by many known pathways, such as tumor cells need to express tumor cell antigen to be detected by the immune system. So sometimes cancer cells do not express those antigens, or many other mechanisms. Cancer cells may be able to acquire the escape phenotype. And back in 2017, we actually published in Nature Communication that the interferon gamma, which is a very important anti-tumor cytokine, we have believed. This in turn, if this interferon gamma is not actually, strong enough to eliminate cancer cells, this interferon gamma in turn induces the genomic instability to the cancer cells and leading to the, more like a genome editing into the cells. So the cancer cells may even acquire the new mutation, and then they progress. So, which means that anti-tumor immune response through interferon gamma production is the double-edged sword. One side is they are very important tumor suppressor, but on the other way around, interferon gamma, the chronic interferon gamma exposure may lead to the tumor cells become more unstable genetically, and then the cancer cells may change their phenotype. So that's why we decided whether what kind of mechanism the tumor cells may be able to acquire after the very strong interferon gamma immunological editing. So we decided to establish those immunologically escaped cancer cells using the animal model. So here I'm going to quickly describe what we have done experimentally. Because of the time limitation, I have to be very brief. But what we usually using is using the mouse tumor system, which is a B16 melanoma. This is the C57BL/6 background melanoma cell line, but expressing OVA, albumin, as a model antigen. So with this cell, because the mouse melanoma cell, but expressing chicken antigen, so they are immunologically really visible. So and then at the same time, we actually also transduce the luciferase gene into this cell to make them light. So with this way, we are able to trace the tumor cell behavior in vivo by using, the special imaging instrument to measure the light from the tumor, and then see whether or not we can trace the exact tumor cell behavior in vivo situation, something like this way. And something adds up more is we actually immunized the animal with this chicken OVA antigen before the tumor inoculation. So we make really mouse get ready to respond to this OVA expressing mouse melanoma cells before the tumor coming. So when we did this experiment, we clearly see the biphasic tumor cell growth after the tumor inoculation. Once tumor cells grow, but eventually it's going to relapse. But then they show the secondary progression. And this is the immunological mechanism. We already proved that experimentally. So this regression phase is depending on the CD8 positive T cell regulation. So the mouse host T cells are actually attacking the tumor and make them regress. But the secondary progression, they actually maybe acquire certain kind of escape mechanism from this T cell pressure. So that's why we decided to establish the cells, the resistant cell line from here. And basically what we believe was that there is a kind of the tumor cells start generating, but after the, under the pressure, certain type of resistant subclone maybe reside here and then expanded. So by analyzing the tumor growing here, may be able to characterize the, the phenotype of the immuno-edited and resistant type of cancer cells. Again, cut the long story short, we did a different kind of experiment. And this is the OVA immunized animal where we are, targeting the experimental group. But we also set up the two different control group. This is a little complicated, so I'm not going to talk about in detail. But basically, they are not immunized normal mouse, but these mouse are immunized animal, but the gene of the interferon gamma was knocked out. So those two mouses, there is no strong immunological pressure and after the tumor inoculation. So what's happened was, as we expected in the OVA immunized animal, the biphasic growth and those new cell lines, and then de-inoculating into the OVA immunized animal, those tumors no longer able to be regulated by the immune system, whereas other two control tumors still keep maintaining their response against the immunity. So these, experiment also indicating that with this IMM cell line we newly characterized, are that they have some certain kind of acquiring the immunological resistance to escape those immunological pressure. So we next examine what happened to those cells, why they are able to escape from the immunological pressure by doing multiple different experiments in vitro. Firstly, very simple experiment. We checked the responsiveness against interferon gamma cytokine itself. As you can see here, this is the parental cell line we originally inoculated into the animal, B16 OVA cell. And if you increase the dose of interferon gamma after the 72-hour treatment, the cell viability of these B16 OVA cells are, the dose dependently decreasing, as you can see here. However, these IMM2, this is a resistant cell line, as I introduced you a bit earlier. They really acquire the resistance to the interferon gamma, as you can see here. If you increase the dose of interferon gamma, they don't really stop the proliferation. Rather, this is a quite in contrast to the two control cell lines. So these and also more than IMM2 cell line, we established 6 of different those resistant cell lines. So this is a summary data, but basically the same message. All those escape variants are acquiring the unresponsiveness to the interferon gamma in vitro. So because most of the interferon gamma biological effect believed to be mediated by interferon gamma receptor signaling. So interferon gamma binds to its receptor, interferon gamma receptor. And then interferon gamma receptor also transduces cytokine signaling, which mainly through a JAK-STAT activation. So we wonder whether those, the escape, cell lines just simply lose their responsiveness to interferon gamma, which means the, less JAK-STAT activation. So we decided to look at the, the typical target of JAK-STAT signaling of interferon gamma downstream, which is the MHC class 1 and PD-L1 expression on the tumor cells. So these two molecules, H2KD, this is the MHC class 1 molecule on the tumor cells, and PD-L1 is, as I introduced you earlier, this is the checkpoint molecule. PD ligand 1 is the direct interferon gamma target molecule. So, and interferon gamma stimulation is very well known to upregulate those two molecules. And as you can see here in the grade histogram, the parental cell B16-OVA with the interferon gamma stimulation, they quickly upregulate these MHC class 1 and PD-L1 expression. As you can see, the histogram shift towards to the right side. But surprisingly, all IMM cell lines, those who are not responding to interferon gamma in terms of cell viability, drop. However, those H2KD, MHC class 1 or PD-L1 expressions are mostly the same to the parental B16-OVA cell lines, which suggesting that those immunoresistant cells we newly established were still responding to interferon gamma, but not really responding to interferon gamma in terms of cell viability or cell like a cytostatic effect. So the second question now comes is how interferon gamma is actually control cancer cell proliferation. That's the next topic. And to cut the long story short, there are many publications around regarding how interferon gamma can manipulate cellular process, including cell proliferation or cell death pathway. And what we identify, wrap up here, is one of the DNA damage response and oxidative stress response seems to be very important for the interferon gamma induced the cancer cell cytostatic effect or affecting cell proliferation. So we decided to look into the oxidative stress response in these immunologically resistant cell lines. So to see the oxidative stress response, the typical target for detecting the oxidative stress response is measuring the intracellular loss ROS expression. And here is the flow cytometry data. If we treat the parental B16-OVA cells with interferon gamma, as you can see, the histogram shift from left to right. Interferon gamma treatment actually induced the intracellular loss level in a parental interferon gamma responding the B16 melanoma cell. Whereas if you look at the resistant cells, there is no induction of those loss expression in all the resistant cell lines, which clearly suggesting that somehow immunologically resistant cells acquire the resistance to the interferon gamma induced loss upregulation. So why that could be happen? That's the second question. Next question we need to answer. So to tackle this question, we subjected to a gene expression analysis for all those different type of cells we established. And again, cut the long story short, this is the red plots are all the immunologically resistant cell lines. So very interestingly, most of those different, the cell lines express the different feature of the gene expression. As you can see here, the three-dimensional PCA analysis showing all the clustering, each individual type of cells are different cluster. But anyway, one of the highlighting difference in these immunologically resistant cell lines are the top 10 and bottom top 10 upregulated genes and downregulated genes are listed here. But among those, what we focusing on was the top gene upregulated was the GSD4. So we decided to look into this GSTA4 gene in the subsequent experiment. So before looking into the detail, we confirmed the expression of GSTA4 gene in the IMM resistant cell lines, but not the other cell lines. And you can see clearly that IMM cell lines, immunologically resistant cell lines, are highly expressing all those GSTA4 genes. And this is also true for the protein expression. As you can see, this is the parental cell lines, but in all those five are resistant cell lines, and all those resistant cell lines are highly upregulating GST expression at the protein expression level as well. So yeah, what we identified here, the immunological resistant cell lines are highly expressing this gene called GSTA4. So what is a GSTA4? The GSTA4 is one of the subtype of glutathione S transferases. And this glutathione S transferases, you may know that these are supposed to detoxifying the enzymes of the cellular electrophilic compounds. So specifically those GSTs, together with glutathione, they actually quenching those, the electrophilic compounds, which is like a loss, including loss. And specifically GSTA4 is known to quenching or detoxifying the molecule called 4-HNE. This is the really the unique and also important intercellular compounds generated as a result of the oxidative stress response. So GSTA4 believed to be important enzyme by detoxifying this 4-HNE. So we then decided to look at whether those immunologically resistant cell, they supposed to be resistant to interferon gamma, but also at the same time they're expressing high GSTA4, so they may be resistant to 4-HNE. So we did that experiment, and as you can see here, other than IMM2 cell lines, they do respond to 4-HNE. However, IMM cell lines, which is a immunologically resistant cell, they are highly resistant to this 4-HNE as well. So this is also summary data. So we got the different type of resistant cell line. They all tend to be resistant to 4-HNE. So these all results suggesting that not only the gene expression, but also the GSTA4 expression in those immunologically resistant cell lines are fully functional. And they are actually, the functionally upregulated. So the next question is whether this GSTA4 is really important for the interferon gamma responsiveness. So to test this, we took the approach in a two different way. One is the using shRNA approach. We are knocking down the GSTA4 expression from resistant cell lines, and then whether we can test make them more sensitizing to the interferon gamma, or on the other hand, we trying to overexpress GSTA4 in a parental cell line, and then whether we can make them as if like a resistant cell line. And the result was both work fine. I mean, as you can see on the left-hand side graph, if you look at the IMM2 cell lines, that's resistant cell lines, they are resistant to interferon gamma compared to the B16 OVA parental cell line. But if we knock down GSTA4, we took the two different sequence of short hairpin RNA, number 1, number 2, both actually bringing them down to response to the interferon gamma, which means knocking down GSTA4 can sensitize those IMM2 cell line, resistant cell line to the interferon gamma. On the other hand, if we actually overexpress GSTA4 into the parental B16 OVS cell lines, that's the white line. And if you overexpress GSTA4, we can push that up to the as similar to the resistant cell IMM2 cell lines in black triangle, the line. So with this two data clearly suggesting that GSTA4 is really responsible for the resistance to interferon gamma in the immune resistant cell line, or would be able to bear the immune resistance in even interferon gamma sensitive parental cell lines. So next question is what is the relevance? Is this GSTA4 pathway new? They are very important for interferon gamma resistance, but what is the relevance of in situ responsiveness to the host immunity? Can we use this molecule as a drug target? So to answer this question, we took into the different experiment where we're using the immunocheckpoint inhibitor anti-PD-1 antibody. So this antibody also work in the mouse system, particularly this B16 OVA, immunologically very visible tumor. So this is the control experiment. If we transplant this B16 OVA tumor into the mouse and treat anti-PD-1, every 3 days from day 3 to 9, then we can see that very strong anti-tumor, the anti-tumor effect of anti-PD-1 antibody, as you can see here. But if we did the same experiment, resistant IMM2 immune resistant cell lines, as I told you, because these resistant cells are really resistant to interferon gamma, and interferon gamma is the very important effector molecule induced by this anti-PD-1 antibody to kill the target tumor cells. So these IMM2 cell lines no longer respond to anti-PD-1 antibody therapy. So this is what we are expecting in the clinic. So some of the patients may not respond to anti-PD-1, and then they may have certain resistance. So if this GSTA4 is important, then the targeting this GSTA4 may be able to deactivating these response against the immunocheckpoint inhibitor. So that's what we have done. So this is a control experiment. With the SH control, transduction, there is no change. But if we knock down GSTA4 in IMM2 resistant cell lines, then these cell lines now become to be response to this anti-PD-1 antibody therapy. So this means very important message that that if we actually reduce the expression of GSTA4, or if we can inhibit the function of GSTA4, we can make those resistant tumor becoming to more, sensitizing to anti-PD-1 therapy, because they are deactivating to the response to the interferon gamma. So that's very important information. Other thing I can add up more is the relevance to the human disease. So because all data shown here was the data based on the mouse system. So here from I'm showing the relevance to the human disease. So this is a human melanoma cell line data. This is a database reanalyzing data. And there are many type of human melanoma cell lines available. And this is the kind of plots where it's showing the mRNA expression of GSTA4 and also the protein expression of the GSTA4 here. And this is a gene chip expression and RNA sequencing expression of the GSTA4. So basically, all aligned to the positive correlation, of course, but amongst different, the human melanoma cell lines, we identified 3 different cell lines: MALMI3M, UACC62, and MIO was expressing GSTA4 very high, intermediate, and very low. And accordingly, we identified that accordingly to this GST4 expression, they actually behave as what we see in the mouse system, like MIO responded to interferon gamma at the best, and where the UACC62 was somewhere in the mediate. And MALMI3M, which expressing the highest GST4, was most resistant among those 3 different cell lines within the human melanoma cells. So these data suggesting that also in the human case, this GSTA4 may be important molecule by the regulating the responsiveness to the interferon gamma. And the last data I'm sharing here is the survival data of the human patients. So this is the high and low expression of GSTA4 according to the gene, on the database. And this is a kind of metastasis-free patient survival data. So if GSTA4 is so that important, they escaping from immunity. And so those patients may have a higher metastatic incidence and also highly immunologically escaping phenotype. So their mortality rate might be the less, than the low expression patient. And the result was showing us exactly that way. If you look at the high and low GST4 expressing patient, the patient, those who have a low expression of GST4, has much better clinical, transition afterwards. So, which suggesting also that this GST4 gene expression may be an important indicator for the melanoma patient progression in the future. So here I'd like to summarize my talk. From this experiment, we identified the redox-related gene GSTA4 is very important gene to protect the immune-resistant cancer cells from interferon gamma-induced oxidative stress response in melanoma cells. And because of time limitation, I didn't show the data, but we also identified this expression of GSTA4 is associated with the metastatic ability of melanoma cells. Those immunologically resistant melanoma cells become highly metastatic, and this is because of the expression of GSTA4. So lastly, I got a little in touch with the human relevance, but the importance of GSTA4 in melanoma, human melanoma, is also shown, and interferon gamma responsiveness and metastatic disease progression. So this indicating that GSTA4 is a very important molecule which governs the resistance to immunity and ability to control metastasizing ability of melanoma cells. That's all I have here, and I'd like to thank to all the collaborators and also all of my students involved in this project. And I have many Indonesian students actually in my lab, and so if you're ever interested in to come to my lab, please do not hesitate to contact me. So that's all I have here, and I'm happy to take any questions. Thanks for your attention.
Thank you very much, Professor Hayakawa, for such an insightful and inspiring presentation. Now, we will open the Q&A session to all participants. Please feel free to submit your questions in the comment section or using the raise hand signal so we could turn on your microphone for direct asking. Is there anyone who want to ask Professor Hayakawa directly? Okay, Professor, it seems there are no question directly asked to you, but I want to ask you a question before. Is that okay, Professor
Yeah,
Hayakawa?
yeah.
Okay.
Yeah.
Professor Hayakawa, you raise a interesting point in your presentation that you say that GSTA4 is required to desensitize and induce immunoresistant cancer cells. So is it possible that we could do something to the GSTA4 modulation, probably, to make the immunoresistant cancer cells is less sensitive to more sensitive into the immune response?
Yeah, I think so. We only have done this approach using shRNA, but if you really want to, targeting the molecule by the drug, for instance, it could be pharmacologically targeted. So yeah, somehow we can manipulate this GSTA4 activity, maybe able to strengthen the anti-tumor immunity in general. So we haven't tested that in combination with, for instance, like immune checkpoint inhibitors, but could be interesting approach.
Thank you for your answer. Okay, next we go to the comment section. The first question is from Ms. Lutfi. Yeah, she asked that what are some of the biggest challenges in translating immunology research discovery into real-world oncology treatments? Professor Hayek?
Yeah. Sorry.
Your biggest challenges in translating your research into real-world oncology treatments?
Yeah, I think that's one side. The coin is how we can translate the basic research into the clinical research. There is some limitation very clearly. I would say what we found in the mouse system is how relevant to the human system is one of the challenging. But nowadays, a lot of the activities are going around on the other way around. So because we have a lot of data available now from the human subject, because now we have many patients treating with the cancer immunotherapy. So from these clinical data sets, we are able to identify the new problems. So for instance, if we interested in certain type of cancer patient who doesn't respond to the therapy, so we actually extracting those character of patients and the analyze or characterizing what's wrong with, and then if we identify certain problem, then we're going to test that problem in the experimental system. So those kind of translational, reverse translational research would make us to more like the confident that our research outcome will be more benefit to the patient directly. So it's been a while. So yeah, that's something challenging. In my point of view, I'm not a clinician, so to access those clinical data sets and also clinical samples are not that easy. So I really need a strong collaboration between the clinical doctors for doing this research. That's one of the most difficult things, I guess, right now.
Thank you, Professor Yoshihiro. And now there are a second question from Mr. Yoga from Universitas Mahasaraswati Denpasar. He want to ask you about, is there any correlation between GST4 molecular signaling and the immune signaling involved in cancer cell resistance. And the second question is that cancer is a very complex disease at the molecular level. Therefore, he would like to know of your approach in identifying the specific molecular targets that you decide to investigate in your research.
Okay, the first question is if I correctly understanding the question, the GST for molecular signaling means because GST4 is an enzyme, so they do not actually transducing the signal. But saying that, I mean, GST4 has their own like the function. So yeah, we do not know why GST4 upregulated. Understanding of those immunological signaling downstream of the interferon gamma, we do not know. However, as I told you, and also within my talk, I mentioned that interferon gamma actually induce the cytostatic effect or the cell viability loss by transmitting not only the cytokine signaling, but also they do introduce certain type of oxidative stress response to the cancer cells. So if there is any oxidative stress response, this GST4 genes is of course because they are like the important enzyme to dealing with those like oxidative stress response in the cells. So perhaps those the intercellular interaction when cells are stressed, and then somehow cells, particularly cancer cells, need to upregulate the molecule to handle with those stress response. And then in our case, that was GST4, but perhaps maybe other molecule may be also able to involve in this process. And that's something we are currently undergoing, the new project undergoing in our lab right now. I think, yeah, so that's my answer for the first question. Second question is, it's very complex in the disease overall. My approach, specific molecular target. Yeah, I think it's again depends on what you are interested in. So in my point of view, I was interested in to understand how cancer cells acquire the resistance against the immune response. That's my priority first. But it comes to this end, we are more interested in how they acquire the resistance against interferon gamma. And to say that we are more and more working on right now how interferon gamma works on the cells. And it's coming to the more like oxidative stress response and those GSTA4. That's something new for me with this project. But now, many of our lab members are right now working on many different aspects of oxidative response, stress response right now. So it's probably depending on what kind of target you are interested in and also what you kind of identifying from the experiments. So yeah, that's I'm sorry, it's not very clear answer, but that's something I can tell you right now.
Okay, Professor Yoshihiro, is it possible if we have another question?
Yeah, no problem. As long as times are okay, yeah.
Okay. This last question is from Mr. Nofran. And how can understanding tumor immune system interaction help pharmacists contribute more effectively to the development and optimization of personalized cancer immunotherapy?
Yeah, that's a great question. I mean, this is, of course, I know the pharmacist conference, and I'm also, as a pharmacist, it's probably very difficult understanding the immunological status of the patient as a pharmacist. But I guess, yeah, I mean, what we need to understand is those mechanism of action of those new drugs of the cancer immunotherapy. For instance, not only just the immunocheckpoint inhibitors, but also there are many treatment using cells and other antibodies. So yeah, I think understanding the mechanism of action and what could be the target for those new therapies in terms of both cancer side and our immune cell side is also very important. Yeah, and to know that, I think we can understand what is the most important point and how we can use those new drugs more effectively. But that's also at the same time it's currently undergoing. I mean, a lot of the clinical studies are still undergoing. How we're going to make more effectively, and even how long we need to treat the patient with new drugs and other things are still under debating. So yeah, probably it's very important to keep in touch with the like brand new informations and you keep updating the new informations as well. Yeah.
Ladies and gentlemen, thank you for the great discussion. To summarize, Professor Hayakawa has shared valuable perspectives on immunology and cancer progression, in particular about how immunoresistant cancer cells proliferate and response to IFN gamma. And not only that, he also give us clue and how we might reverse these immunoresistant cancer cells via GSTA4 modulation. Sadly, due to his busy schedule, Professor Hayakawa might not be able to stay with us until the end of the day. However, Professor, we truly appreciate for your time and contribution that you have given us today. And ladies and gentlemen, let us give another warm round of applause for Professor Hayakawa. And now, we move to our second speaker of this session. Okay, our next speaker is Dr. Apoteker Kurnia Rahayu Purnomosari, Master of Science. She is a faculty member at Universitas Jenderal Ahmad Yani, Yogyakarta, Indonesia. Allow me to briefly present Dr. Kurnia's professional profile. Dr. Kurnia completed her bachelor, apothecary, master, and doctoral degrees at Faculty of Pharmacy, Universitas Gadjah Mada. She is an active lecturer and researcher with expertise in natural product research. In Indonesia's national research system, she holds SINTA score of 438 with 3-year scores of 200. And she has a Google Scholar Edge Index of 5 and Scopus Edge Index of 2, which reflecting her growing academic impact as a young researcher. Her publication span from ultrasound-assisted extraction, Plantago major bioactivity, and natural product formulation, appearing in various journals such as Journal of Advanced Pharmaceutical Technology and Research, the Indonesian Journal of Cancer and Chemoprevention, and the Journal of Biotechnology and Natural Science. She has also received many notable recognition, including the prestigious doctoral scholarship from the Ministry of Higher Education and Technology of Indonesia, as well as the Best Oral Presenter Award at a national symposium. Her dedication to research, teaching, and scientific developments makes her one of the most promising emerging scholars in Indonesia pharmaceutical field. Ladies and gentlemen, please join me in welcoming Dr. Apoteker Kurnia Rahayu Purnomosari. Hello, Dr. Kurnia. We are delighted to have you here. How are you feeling today?
Yeah, hello. Yeah, I'm feeling wonderful today.
Okay, thank you, doctor. Before we begin, may I would you like to share short messages with the audience, perhaps about our theme for today?
Yeah. Thank you for the opportunity that having me here to share about our recent update in global health issue. And maybe for me, as a pharmacist in Indonesia, that we have very important role today in global health landscape. Yeah. With our rich biodiversity and strong tradition in herbal medicine, we are in unique position, of course, to contribute solutions that are both scientific and sustainable. As someone working in a biological pharmacy and herbal development, I believe our responsibility is not only to ensure the safety and quality of herbal product, but also to transform Indonesian natural's potential into evidence-based innovation that can support global health well-being. Thank you.
Wow, that's a very good point to make. Yeah, we as pharmacists need to grow and evolve, yeah, to answer to these challenges. Now, without further ado, please welcome our second speaker, Dr. Apoteker Kurnia Rahayu Purnomosari, to present her material. To Dr. Apoteker Kurnia Rahayu Purnomosari, the screen is yours.
Okay, let me share the presentation. Okay, is it already here?
Yeah.
Okay.
We already
Yeah.
see your PowerPoint. You may
Okay.
continue, Dr. Kurnia.
Yes, of course, yes. I'm good. Okay, thank you once again for having me here. And I would like to bring up some terms for the pharmaceutical biology subject. Is it about the advancing green extraction technologies for herbal medicine with a QBD-based approach? Let me begin with one framing question about the development of the pharmaceutical product. What if the future of the skincare, medicine, and wellness could be built not only on scientific innovation, but also on environmental responsibility? Imagine an extraction technology that delivers high efficacy herbal medicine without harming the planet where we are alive, align with the global sustainability goals, and empowers local biodiversity. This is not a distant vision. This is the promise of the green extraction that process that correspondent at the intersection of SDGs of sustainable development. Number 3, which is good health and well-being, SDGs 12, responsible consumption and production, and SDG 13 about climate change action. But innovation in herbal extraction is not just being green. It's about being precise, predictable, and reproducible. And that is where quality by design, or we know as QBD, comes in, with its discipline, structure, and science-based decision making. Today, I will share how we combine this powerful concept between green extraction and QBD to develop high-quality herbal products, and how our recent research on Plantagomire shows the real potential of this approach. Okay. About green extraction, that was refer about the extraction of bioactive compound from planets or from our environment using ecological friendly solvent, low temperature, and sustainable processes. The advantage of the green extraction is that we can minimize the environmental impact, enhance the quality and efficacy of herbal products, and adhere to the health and safety regulation, so that we can enhance consumer safety and regulatory compliance. As the demand for natural product grows, industry are pressured to adopt methods aligned with clean production, carbon reduction, and circular economy principle, all of which support global SDGs. And quality by design is a systematic approach to product development that focuses on understanding and controlling the process itself. Usually in pharmaceutical sciences, we know quality by design is for formulation of product, pharmaceutical product. But now this QBD can apply in the extraction processes. In green extraction, QBD itself, we should identify key variable in the extraction process that can affect the result, such as extraction, temperature, duration, and solvent. And then creating or determining the crucial parameter to ensure the consistency and quality of the finished output. So how can the QBD approach apply in this green extraction technology? The QBD approach can be applied in a systematic and planned manner to ensure high quality of herbal product. So by applying the QBD, we need emphasis from step and how QBD can be applied. The first one, we need to determine the critical process parameter, or it's known as the independent variable in the experimental design. This is important so that we should control this parameter in the process of extraction. Identify variable that can affect extraction results, such as type of solvent, like water, ethanol, or supercritical carbon dioxide, and then extraction temperature, extraction time, and ratio of raw material and solvent. And the second one is that we should determine the critical quality attribute, or as we know it as independent variable. Determining the quality attribute that the final product must meet, such as compound purity, biological activity, product stability. So we need design of experimental, or we known as DOE. You can evaluate how much each variable and the interaction between variables affect the extraction result. DOA itself, we're using the statistical design of experimental. We use the design or method design experimental that can identify the relationship between the dependent and independent variable. This will help mapping the effect of the variable on the product quality. For example, conducting an experiment to determine how variation in temperature and extraction time affect the purity of the active compound extracted from ginger. And after that, we need to analyze the result. So using statistical analysis to evaluate the data obtaining from the experiment and determine the optimal extraction condition. And then the last one, we do the process optimization based on the analysis result to maximize extraction yield and product quality, or as independent variable. So in short, at the first step, how we do this design of how we design this experimental. First, we need a literature review, about what is the purpose we develop this extract, or this compound, or what are our goals for this extract to be developed in the future. So we need the literature study. For the first step, for example, we want to develop some extract as the anti-aging agent. So we need to investigate which phytochemical compound that are involved in this activity. And that point can be used as dependent variable. And follow this action, we need to investigate the compound, or the characteristic of each compound and the condition that allow for effective and non-destructive extraction. This site will be or can be used as the independent variable. So after the analyzing the method, we can do the modeling, optimization of the modeling using DOA, and then optimization to get one condition atau or one optimal condition. Okay. Nah, this is some example how this extraction or green extraction with combined with the QBD. Yeah. The recent update such as application of microwave assisted extraction for the paper bottle. Yeah, this method using optimized critical parameters such as microwave power and then extraction time, solid to solvent ratio. And then the optimal condition is for the microwave power is 239.6 with the extraction time of 1.58 minute. And the solid to solvent ratio is 1 to 22 gram per milli. And this research can obtain higher antioxidant and antibacterial activity. And the second one is HPLE or a hot pressure liquid extraction in blueberry. The optimal condition that obtained is for 130 degree of Celsius with a 30% of isopropanol, and they can obtain highest phenolic content and antioxidant capacity. And curcuma longa that was developed using supercritical carbon dioxide extraction that was obtain more selective extraction of curcuminoids, and they can get cleaner and solvent-free product with this method. And for UAE, ultrasound assisted extraction, there's some research about it, about around 2020 to 2025. Key finding about this UAE is that some variable have important roles in extraction using UAE, such as extraction time and then solvent concentration, amplitude, temperature, and is the best or the most significant variable that can affect the process. UAE demonstrate an increase in yields, improved PCNTFC, stronger antioxidant and biological activity, lower extraction time and energy. So this study, some study confirmed that UAE is a robust, green, and QBD-friendly technique of extraction. And how about application in our recent research? My recent research is to optimization of Plantago leaf extract production and exploring its activity as anti-photoaging in fibroblast cell irradiated with UVB rays. Yeah. Why we choose the Plantago major here? Like I mentioned before, that we do literature research, and we know that the Plantago major, or in Indonesia we know it as daun sendok, has some phytochemical compound that have been previously studied have activity related to skin condition improvement pathway. This compound such as albumine, plantamajusate, and some phenolic and flavonoid content. The activity that related to skin condition improvement is for anti-inflammatory effect pathway, UV protection, collagen synthesis enhancement, and reduction of matrix metalloproteinase. So, of course, we want to extract all of these phytochemical content optimally. And how we can obtain it so that we can get an effective extract. That's why we use QBD or quality by design and utilize response surface methodology with box Penken design. This is our goal in herbal extraction. To achieve result that not only effective but also efficient. So to get this goal, it's essential to combine practical experimentation with strong foundation of knowledge. By understanding this previous finding about the Plantago major, identifying key factors that may affect the extraction method, and learning from validated scientific evidence, we can design extraction conditions that are more precise, targeted, and reliable. In other words, literature-based parameter selection allows us to optimize efficacy without compromising the quality and effectiveness of the final extract. Ultrasound-assisted extraction itself method, like they can create the cavitation bubble in the extraction medium. So this bubble will accelerate the diffusion process of the compound in the plant cell, improve mass transfer of target compound, and it will be more efficient than conventional masterization extraction method. From the literature review, we know that some of independent variable that may affect the result of the extraction. The first is extraction time. This is very crucial. There's an optimal range, often in the middle, but not absolute in the minimum or maximum. This depends on the plants or herbal to ensure the yield and compound content are not low or degraded. And then solid and solvent ratio, this is affect the extraction efficiency. If it's too concentrated or too dilute, it can reduce the extract yield per mass. And then solvent concentration, such as a percentage of ethanol in the mixture, it's important to extraction secondary metabolites such as phenolic, flavonoid, or anthocyanin. And ultrasonic frequency can be determined the intensity of cavitation bubbles. This amplitude or frequency or intensity can affect the solvent penetration and the efficiency of bioactive compound released from the plant tissue. And extraction temperature, I'm sorry. Although UAE is often performed at low to medium temperature, temperature control is important. So we don't want all phytochemical compound will be degraded. And then control temperature and mixing homogeneity or solvent movement. This is to ensure even solvent distribution and ultrasonic penetration in the plant tissue. Okay, and next is that in our research, we design the independent variable. The first one is temperature. We set it from minimal 20 degree of Celsius to 50 degree of Celsius, and then extraction time from 20 minutes to 60 minutes, and then solvent, solute and solvent ratio, and then ethanol concentration. And for the RSM-BBD, they give 27 batch extract that we should do in the laboratory. So we do the extraction for these 27 condition, and of each batch of extraction, we determine the dependent variable. The first one is the yield, and then total flavonoid content, total phenolic content. We use determination using microassay method, and then albumine, we use HPLC PDA, and planta majosate using HPLC UV. And the last one is collagenase inhibition activity. We use enzymatic in vitro method. After we do the extraction and determine all the independent variable, determine the dependent variable from 27 batch, then we do the analyze from each dependent variable model equation. Here we know the yield, TFC, TVC, albumine, pantamajosate, and inhibition, collagenase inhibition have its model equation, and the difference are here between the multiple and adjusted is less than, the differences is less than 0.2. So it means that the predicted and actual model by RSM are correlated. And when we see the p-value in every dependent variable, all of them are below the 0.05. It means that the independent variable that was used in the extraction condition using UAE method can affect the established dependent variable significantly. After we have each equation and we sure that this model can be used for the next analyze, we ask the RSM or response surface methodology to predict one condition that will have optimal dependent variable. So the RSM itself, they give the first solution with desirability value on 0.759 and 9. For the temperature, the optimal temperature for extraction is 50 degree of Celsius, and then extraction time for 20 minutes, ethanol concentration 69%, and solute to solvent ratio 1 to 5.6 weight per weight. So this is the result from the actual and prediction. So prediction is from RSM value. They predict with extraction in this condition, they will have exact yield, TFC, TPC, albumin, plantamidosat, and collagen inhibition. And we analyze it with the actual that we get from the laboratory. And the result based on statistical is no significant difference between actual and prediction. So it means that the RSM method can be used to assess in the extraction optimization process because the prediction result from the RSM system did not differ significantly from the actual experimental value for its response variable. How about UAE and conventional maceration? Does UAE have great effect if we use it with the constant maceration on conventional maceration? From the phytochemical content, analysis of the phytochemical content like TFC, TVC, albumin, and plantamidosat is show that UAE give higher result in all the phytochemical content, significantly higher than the conventional maceration. So this is demonstrating clear superiority from the UAE as the green extraction than the conventional maceration. Ultrasound assisted extraction significantly enhance process efficiency by generating cavitation bubbles. So it helps disrupt the plant cell wall. So the mass transfer is improved. As the result, the phytochemical content that obtained through this method is higher than the produced by conventional maceration. And how about the in vitro activity determination? In fibroblast cell line, we do the evaluation in cell viability, the collagen deposition, and mRNA expression in MMP1, SMART3, collagen 1, and collagen 3, sorry. And it showed that the plantamidosat can have plantagomayor show the great activity or strong anti-photoaging potential to be developed future. The extract itself has increased cell viability, collagen deposition, mRNA expression on 3 and SMART3, but can decrease the MMP1 expression. So what is the challenge and the opportunity of this method? The challenge is about the initial cost. The initial investment for green extraction equipment can be high. For example, SFE requires expensive equipment. So it means that we need initial investment and need for advanced skill in QBD and statistical modeling. limited industry adoption in developing region. But the opportunity is that market growth, the market for high quality herbal product continues to expand. So consumers are becoming increasingly aware of the health benefit of natural product. And product innovation, green extraction technology enables the development of new products that are more effective and safe. So what's next? We need green extraction technology, and the QBD approach can improve the quality and sustainability of herbal products. We need collaboration between researcher, industry, and regulatory. It is crucial to address challenges and maximize the potential of innovation. Further research to develop and optimize green extraction method and policy development to support the use of sustainable technology in the herbal industry. I believe by applying the QBD approach to green extraction technology, manufacturers can ensure that the resulting herbal products are not only high quality, but also safe and environmentally friendly. Because QBD allow for more planned and measurable product development, reducing the risk of failure and increasing consumer satisfaction. So there's minimize the research itself. By aligning innovation with sustainability, we are not only improving the product, we are contributing to the global SDGs and shaping the future responsible herbal medicine production. Thank you for the time. I think it's enough for me.
Thank you, Dr. Kurnia, for a very clear and enriching presentation. We now open the next Q&A session to our participants. Please feel free to type your questions in the comment section or use the raise hand signal so we could turn on your microphone. Do we already have some question? Okay. We already have a question for you, Dr. Kurnia. This one is coming from Miss Enda. Her question is, can you share your future research plans and what if, on an industrial scale, you obtain extract results that are significantly different from your research findings?
Okay, yeah, thank you for the question. Actually, for now, we are in the process for optimizing or transferring technology to the herbal industry. So from the laboratory to the industry. Of course, we need to some modification because in industrial scale, especially in Indonesia, they are not ready with ultrasound in the big scale. So we have to do some do some modification, yeah, to get the extract that we want with the phytochemical profile. So maybe as we still want to get our product in the lab to the community. So we need to move forward to keep produce it in the industrial scale. And therefore, the next possibility, yeah, the feasibility for the development is to choose a method that can produce an extract closest to the target about the phytochemical compound, and then maybe adjust the dosage in the product formulation. This is what we can do for now, while waiting for the herbal industry can adopt the ultrasound technology in their extraction process. Maybe that current update for my research right now.
Okay. And the next question is from Mr. Sukma from Universitas Gadjah Mada. His question is, in the context of supercritical fluid CO2 extraction of curcuma longa, Which critical process parameters should we prioritize in a design of experiment framework? And how can DOE effectively detect and model interaction or nonlinear effects that may significantly impact extraction yield and bioactive compound quality? So how you choose your critical process parameters for supercritical fluid CO2 extraction, and how DOE could explain the interaction and the nonlinear interaction. Dr. Kurnia, I think you got muted.
I'm sorry. Okay. So in supercritical extraction, of course, we need to know this method, what will be the most crucial. So we can do the literature review first about this method. There's some previous research about this method, and for the curcuma longa, for example, we want to get the maximum curcuminoid, so we should know what parameter that will affect this compound, such as maybe if the curcuminoid will be degraded by high or sensitive with the heat, so we should make this heat as the critical parameter in the process or the design of experimental framework. And how can DOA effectively detect and model interaction or nonlinear effect that may significantly? Okay, we can choose by the model equation itself. So we should know the model equation for each parameter or dependent variable, and then we can know what kind of parameter that will impact the most. Like from my research, in my research, all p-value and the R difference all we have the significant affection to the dependent variable. But sometimes the p-value maybe for the yield is above 0.05. So we can conclude that this dependent variable is not affect the yield of the extraction. So we can see one by the parameter what we want to analyze between the dependent and independent variables. This is maybe for me, Mr. Aska.
Okay, thank you for your answer, Dr. Kurnia. And the last question is coming from Ms. Khalif. Her question is, if experimental results show that increasing ethanol concentration improves phenolic extraction, but decreases aucubin yield, how would you use DOE to identify the optimal extraction condition that balances both outcomes?
Okay. For this question, actually, DOA approach help balance conflicting responses. We can model both TPC and aucubin across varying ethanol concentration and other factors such as temperature and time of extraction. And when we use the multi-response optimization, like typically desirability function, we can identify a compromise condition where the phenolic content remain high while the aucubin stay within acceptable range. So confirmation will run, then verify that the chosen point produce both good chemical quality and stable biological activity. So for example, in my extract, I know that the phenolic compound will contribute more to the activity. So I can design that my extract, the priority is I want the extract with the highest TPC or phenolic content, but I still need albumin is in the some range, not the not the maximize, but in the range that I can stay within a acceptable range. So it's depend on our design or what we need for the extract. That's why the QBD is important, because we are not just extract and analyze the activity. It's not like that, but we think about I want to make or I want to produce extract that can inhibit early aging because of photo UVB. So the mind map is reverse because the conventional method is that we extract, use a certain method, and then we do the analyze. Is it good for the antioxidant? Is it good for the antimicrobiology or anti-inflammation? But the QBD, we have the dream about this product. What will we gonna do with it, this product next? And we do literature review to get this product. So we controlling the process from the first extraction, and then later from the for the transfer it to industry. It's what can I explain about QBD.
Okay, thank you, ladies and gentlemen, for the thoughtful question and discussion. To summarize, Dr. Kurnia has provided an insightful perspectives on advancements and potential of green extraction process, in particular applying QBD approach that already in use for formulation to optimize the green extraction method. Thank you very much, Dr. Kurnia, for sharing your expertise with us today. Ladies and gentlemen, that concludes our scientific session for today. On behalf of the committee, I would like to thank our two distinguished speakers and all participants for joining us. We hope today's discussion will inspire new ideas, new collaborations, and new innovations in pharmacy and pharmaceutical science. Enjoy the rest of the conference and have a wonderful day.
Thank you, Mr. Aska, for leading us through the second session, which is also our last session for today. That was an excellent presentation, and we have gained many valuable insights and inspiration from our four distinguished speakers. I would like to extend my heartfelt appreciation to all of the speakers for generously sharing their knowledge with us today. As we come to the end of today's session, we would like to once again remind all the participants to complete the attendance through the link provided by the committee and share in the chat room. We would also like to express our sincere gratitude to all distinguished speakers, moderators, and participants for your meaningful contributions and attentions. We hope our today's discussion will inspire new perspective and strengthen future collaborations in pharmacy practice and research. Our appreciation also goes to all co-hosts and sponsors who have supported this event. Special thanks to our co-host, Universitas Jenderal Ahmad Yani Cimahi, Universitas Gadjah Mada Yogyakarta, Universitas Muhammadiyah Yogyakarta, Universitas Hang Tuah Surabaya, Universitas Mandala Waluya Kendari, Universitas Pekalongan, Universitas Jember. Sekolah Tinggi Ilmu Kesehatan Maluku Husada. Universitas Nadatul Ulama Yogyakarta. Universitas Sumatera Utara. Sekolah Tinggi Farmasi Indonesia Bandung. Sekolah Tinggi Farmasi Padang. Universitas Bengkulu. Universitas Wahid Hashim Semarang. Akademi Farmasi Yogyakarta. Universitas Mahasaraswati Denpasar. I3L University Jakarta. And also thank you for our sponsor, CV General Labora, PT Abadi Nusa Usaha Semesta, PT Ditek Jaya, PT Kairos Jaya Sejahtera, PT Almega Sejahtera, CV Krishna Utama, Obat Apps. Thank you very much for your support. We look forward to meet you again tomorrow for the second day of our international conference. Thank you and have a wonderful day. I am Widya Dwi Handayani, sign off. Wassalamualaikum warahmatullahi wabarakatuh.
Di usia yang masih sangatlah muda, Unjaya terus bertransformasi, mewujudkan cita-cita menjadi universitas yang unggul dan berwawasan global. Sebagai universitas milik Yayasan Kartika Eka Paksi, di bawah binaan langsung TNI Angkatan Darat, Unjaya menjawab tantangan pendidikan tinggi di era disrupsi dengan bertransformasi melalui penguatan wawasan global dan ketahanan nasional dalam visi dan misinya, serta berpegang teguh pada nilai-nilai kejuangan Jenderal Ahmad Yani. Berbagai prestasi di bidang akademik, kreativitas, inovasi, dan kemahasiswaan banyak dicapai para Ahmad Yani muda. Selain itu, pengembangan keilmuan melalui metode student-centered learning dan project-based learning, magang, program kewirausahaan mahasiswa, festival karya mahasiswa, dan Ahmad Yani Mudapreneur merupakan salah satu bentuk transformasi ekosistem Unjaya agar mampu berdampak lebih luas bagi masyarakat. Sebagai lanjutan dari upaya penguatan internal dan transformasi digital, Unjaya menata kembali hubungan antar unit kerja untuk meningkatkan layanan yang efektif, efisien, dan transparan sebagai tanggung jawab perguruan tinggi sebagai salah satu lokomotif perubahan. Proses transformasi tersebut ditandai dengan aktivasi Pusat Akses Terintegrasi untuk Optimalisasi Tata Kelola atau Patriot. Patriot merupakan sistem informasi terintegrasi yang menyatukan semua layanan di Unjaya dalam satu genggaman. Transformasi tersebut menjadi salah satu bentuk komitmen Unjaya untuk membentuk masa depan pendidikan yang menjangkau lebih banyak, melayani lebih dalam, dan berdampak lebih luas bagi generasi penerus bangsa yang nasionalis, patriotik, heroik.
Yogyakarta adalah kota yang penuh dengan sejarah, budaya, dan semangat kebangsaan. Kota di mana setiap jalan berasa dijahit erat dengan kisah-kisah kepahlawanan dan pengabdian kepada negara. Dan di tengah-tengah gemerlapnya Yogyakarta, terdapat sebuah institusi pendidikan yang mengemban misi besar. Selamat datang di Fakultas Kesehatan Universitas Jenderal Ahmad Yani, sebuah tempat di mana semangat kebangsaan dipelihara dan para pemimpin masa depan kita dibentuk. Di sini, para pendidik bekerja tanpa lelah untuk memastikan bahwa pendidikan yang diberikan sesuai dengan standar pendidikan nasional. Mereka adalah pemimpin yang bijaksana yang membimbing mahasiswa dalam perjalanan mereka mencapai mimpi dan potensi tertinggi mereka. Fakultas Kesehatan Universitas Jenderal Ahmad Yani memiliki 8 program studi. Prodi Keperawatan S1 merupakan program pendidikan tahap akademik yang bertujuan untuk mempersiapkan mahasiswa menjadi calon perawat profesional melalui pendidikan berkelanjutan pada tahap profesi. Pada tahap akademik ini, mahasiswa dibekali dengan pengetahuan terkait teori dan dasar-dasar ilmu keperawatan melalui pembelajaran di kelas, laboratorium, dan juga praktik. Prodi Profesi Nurse merupakan program lanjutan dari pendidikan sarjana keperawatan untuk mempersiapkan lulusan menjadi perawat profesional. Pengalaman belajar dilaksanakan di rumah sakit, puskesmas, klinik maupun masyarakat selama 1 tahun. Prodi Kebidanan D3, program pendidikan vokasi yang mempersiapkan mahasiswa untuk menjadi bidan yang terampil dalam memberikan pelayanan kebidanan kepada remaja, ibu hamil, ibu melahirkan, ibu pasca melahirkan, bayi baru lahir, neonatus, bayi, balita, dan ibu klimakterium, serta terampil dalam memberikan pelayanan komplementer kepada ibu dan anak. Prodi Kebidanan S1 merupakan program studi yang mempersiapkan mahasiswa menjadi calon bidan profesional yang secara akademik dipersiapkan untuk menempuh jenjang pendidikan profesi, sehingga dapat memberikan pelayanan kebidanan sesuai kompetensi bidan. Prodi Profesi Bidan. Prodi Profesi Bidan merupakan program lanjutan dari pendidikan sarjana kebidanan untuk mempersiapkan lulusan menjadi bidan profesional. Pada tahap ini, mahasiswa dibekali dengan pembelajaran praktik di berbagai wahana praktik, meliputi rumah sakit, puskesmas, klinik pratama, dan praktik mandiri bidan yang ditempuh selama 1 tahun. Prodi Rekam Medis. Program studi ini membekali mahasiswa dengan pengetahuan dan keterampilan untuk mengelola informasi medis dan kesehatan berbasis elektronik, termasuk pengumpulan, penyimpanan, analisis, dan penggunaan data kesehatan yang penting untuk pengambilan keputusan klinis dan administratif. Prodi Teknologi Bank Darah. Program studi ini fokus pada pengembangan teknologi terkait pengelolaan penyediaan dan penggunaan darah untuk kepentingan transfusi dalam konteks pelayanan kesehatan, termasuk proses pengumpulan, pengamanan, penyimpanan, pengujian mutu dan distribusi darah, serta produk darah lainnya. Prodi Farmasi S1, program studi farmasi ditempuh selama 4 tahun untuk mempersiapkan mahasiswa menuju jenjang profesi sebagai apoteker profesional. Pada program studi ini, mahasiswa akan mempelajari tentang obat-obatan, dosis, efek samping, interaksi obat, dan cara memberikan informasi serta layanan farmasi kepada pasien guna mewujudkan kesehatan yang optimal. Di sini, kami bangga menyediakan sarana dan prasarana bagi mahasiswa untuk meraih potensi terbaik mereka. Ruang kelas. Ruang kelas kami didesain dengan nyaman untuk menciptakan lingkungan belajar yang inspiratif, dilengkapi dengan teknologi terkini dan fasilitas yang memadai. Setiap kelas mencerminkan standar kualitas tinggi kami dalam pendidikan. Ruang tutorial, tempat di mana diskusi dan interaksi antara dosen dan mahasiswa menjadi inti dari pembelajaran. Ruang tutorial kami dirancang untuk mendukung kolaborasi dan pemahaman mendalam tentang materi pelajaran. Lab terpadu. Laboratorium terpadu menyediakan fasilitas lengkap untuk pembelajaran praktikum mahasiswa semua program studi. Dengan peralatan modern dan ruang yang luas, mahasiswa dapat mengeksplorasi konsep-konsep ilmiah secara praktis. OSCE Center. Di sini, mahasiswa dapat mengasah keterampilan klinis mereka melalui simulasi yang realistis. OSCE Center dilengkapi dengan fasilitas terkini untuk mempersiapkan mahasiswa menjadi tenaga kesehatan profesional. Lab komputer. Fasilitas laboratorium komputer menyediakan akses ke perangkat keras dan perangkat lunak terbaru. Dengan ruang yang nyaman dan fasilitas yang lengkap, mahasiswa dapat mengembangkan keterampilan teknologi yang diperlukan di era digital ini. Lab CBT, Computer Based Test. Lab ini dirancang khusus untuk ujian berbasis komputer, menguji pemahaman mahasiswa dalam format yang interaktif dan adaptif. Ruang webinar. Kami juga menyediakan ruang webinar yang dilengkapi dengan teknologi mutakhir. Fasilitas ini juga bisa untuk menyelenggarakan seminar, workshop, dan presentasi online yang interaktif dan informatif. Asrama mahasiswa. Untuk kenyamanan dan kemudahan akses, kami menyediakan asrama mahasiswa yang modern dan aman. Ini adalah tempat yang nyaman bagi mahasiswa untuk tinggal dan berkembang dalam suasana akademis yang mendukung. Perpustakaan. Koleksi perpustakaan kami mencakup berbagai sumber belajar, mulai dari buku dan jurnal, baik cetak maupun elektronik. Ini adalah tempat yang ideal bagi mahasiswa untuk mengeksplorasi pengetahuan dan melakukan riset. Student Corner. Tempat bertemu, berdiskusi, dan berkolaborasi antar mahasiswa. Student Corner adalah pusat kegiatan sosial dan akademis di kampus kami. Lapangan basket. Untuk menjaga keseimbangan antara belajar dan kesehatan jasmani, kami memiliki lapangan basket. Ini adalah tempat yang sempurna bagi mahasiswa untuk melepaskan energi dan menjaga kebugaran fisik. Apotek. Kami juga menyediakan apotek di kampus, memastikan kebutuhan kesehatan mahasiswa dan masyarakat umum terpenuhi dengan baik. Fakultas Kesehatan Universitas Jenderal Ahmad Yani siap membentuk para Ahmad Yani muda yang nasionalis, patriotik, heroik. Bersama-sama kita akan melangkah maju menuju masa depan yang lebih baik untuk kemajuan Indonesia. Mari kita bersama-sama menjadi bagian dari perubahan di Universitas Jenderal Ahmad Yani.
Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta siap mendidik dan mempersiapkan para Ahmad Yani muda bidang kesehatan sebagai generasi penerus kejayaan bangsa Indonesia.
Unjaya, nasionalis, patriotik, heroik.
Yogyakarta, kota istimewa yang dikenal sebagai denyut nadi pendidikan Indonesia. Disinilah ribuan mimpi dan cita-cita masa depan dirajut di tengah atmosfer akademisi yang kental ini. Universitas Jenderal Ahmad Yani hadir sebagai kawah candra di muka, mendedikasikan diri untuk melahirkan generasi kesehatan yang unggul dan berjiwa kebangsaan.
Selamat datang di program studi farmasi S1 Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta, Unjaya. Prodi Farmasi Unjaya memulai operasional pembelajaran pada tahun 2017 dan telah memperoleh akreditasi B dari LAMPTKES pada tahun 2021. Prodi Farmasi Unjaya berkomitmen untuk terus meningkatkan mutu menuju akreditasi unggul. Misi Prodi Farmasi adalah menjadi program studi yang unggul, berwawasan global, memiliki penciri promosi kesehatan di bidang kefarmasian yang berbasis bukti, dengan semangat kejuangan Jenderal Ahmad Yani. Prodi Farmasi Unjaya memadukan pendidikan kefarmasian yang berwawasan global dengan promosi kesehatan berbasis bukti, agar lulusan tidak hanya menguasai obat dan produk kesehatan, tetapi juga mampu berperan aktif dalam edukasi, advokasi, dan pemberdayaan masyarakat.
Perkuliahan dirancang selama 8 semester dengan total 146 SKS, mengacu pada kurikulum KKNI, APTFI, serta standar profesi apoteker.
Pembelajaran menerapkan pendekatan student-centered learning untuk menumbuhkan kemandirian dan berpikir kritis.
Prodi Farmasi Unjaya didukung fasilitas pembelajaran lengkap, modern, dan terintegrasi sistem informasi. Mulai dari ruang kelas representatif, perpustakaan dengan koleksi pustaka yang memadai,
Ruang CBT, evaluasi dilakukan secara objektif melalui Computer Based Test CBT. Ruang OSCE, Objective Structure Clinical Examination OSCE, guna menjamin kompetensi yang terukur. Kegiatan akademik diampu oleh dosen berpengalaman dengan kualifikasi profesor, doktor, dan magister dari 5 kelompok keilmuan.
Dosen kelompok keilmuan teknologi farmasi, dosen keilmuan teknologi biologi farmasi, dosen kelompok keilmuan kimia farmasi, dosen kelompok keilmuan farmasi klinik dan komunitas, dosen kelompok keilmuan manajemen farmasi. Serta didukung oleh staf kependidikan prodi yang terdiri dari laboran dan admin. Juga memiliki laboratorium terstandar yang terdiri dari Laboratorium Teknologi Farmasi, Laboratorium Kimia Farmasi, Laboratorium Biofarmakologi, Laboratorium Bahan Alam dan Mikrobiologi, Laboratorium Farmasi Klinik dan Komunitas, serta Laboratorium Instrumen dan Penelitian. Mahasiswa Farmasi Unjaya aktif memperoleh pencapaian di berbagai ajang kompetensi bergengsi tingkat nasional, khususnya dalam bidang kefarmasian, sains, dan riset ilmiah. Kami mempersiapkan sarjana farmasi berwawasan global, adaptif, serta berkarakter profesional dan humanis. Selain keunggulan akademik, kami juga fokus pada peningkatan leadership dan soft skill mahasiswa melalui Himpunan Mahasiswa Farmasi atau Himafar. Berbagai kegiatan prestatif rutin dilaksanakan, mulai dari keikutsertaan dalam International Society Pharmaceutical Engineering (ISPE), pelatihan kepemimpinan manajemen mahasiswa farmasi (LKMMF), musyawarah besar, Pharmafest, hingga berbagai workshop pengembangan diri. Ekosistem organisasi yang kuat terbukti melahirkan budaya prestasi yang gemilang. Profil lulusan kami mencerminkan integrasi ilmu dan etika sebagai caregiver, communicator, decision maker, manager, leader, researcher, teacher, entrepreneur, long life learner, serta health promoter. Lulusan sarjana farmasi memiliki peluang karir luas dalam pelayanan kefarmasian di rumah sakit dan apotek, industri farmasi pada bidang produksi, QC dan R&D, regulasi pemerintahan di BPOM atau Kemenkes, wirausaha produk herbal dan startup digital, hingga menjadi akademisi dan peneliti. Upaya kami adalah terus meningkatkan kualitas dan menghasilkan lulusan berkarakter. Bergabunglah bersama kami program studi farmasi Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta.
Farmasi Unjaya, nasionalis, patriotik, heroik.